Good. Call, please just reach out to Kitty Boji, my colleague here at CPAD, or myself, Wendy Vanasco. Our emails are listed here. So, and we'll show this throughout a few times throughout the presentation. So, but if you need anything at all, please feel free to reach out to either of us at any time. And with that, I am going to introduce John Michael Sauer. John Michael is the Senior Vice President of the Translational and Safety Sciences Program here at CPAD, and he is also the Executive Director for the Polycystic Kidney Disease Outcomes Consortium. So John Michael, I am going to turn this over to you.
Thanks a lot, Wendy. Welcome everyone to the PKD Regulatory Summit. We've all been looking forward to this. Hopefully everyone has had an opportunity to go ahead and look at the pre-recorded presentations. Today what we're going to do, why don't we go to the next slide, Wendy? Go to the next slide, please. Today what we're going to do is really concentrate on panel sessions, but before we get started with that, what I'd like to do is to thank our sponsors for the summit. First of all, the PKD Foundation and their help in pulling the summit together, as well as sponsoring it, as well as, on the next slide, Otsuka for their sponsorship as well. Without this funding, it would be very difficult to pull off a webinar of this type. So why don't we get to the next slide, Wendy? And I'd also like to thank the planners and organizers for the summit. We've been working with everyone for the past several months to go ahead and pull this all together. So special thanks to Wendy and Kitty and the CPAS staff for them coordinating all these activities. And then of course, Ron, Chris, Frank, and Elise for their contributions in pulling together the content and working with the speakers to make the summit happen. So next slide, please. So today, what we're going to be going through on day one is looking at ARPKD, and hopefully everyone's had an opportunity to go through the pre-recorded talks. Ron Perrone will start off with a introduction to the session. We'll then go ahead and have a patient speaker, Julie Marshall, give a talk, and then we'll have an in-depth panel discussion. The second session will be on ADPKD. Chris will go ahead and give an introduction around that. And then Hayley will go ahead and give the patient perspective on ADPKD. And then we'll go into the panel session. We'll wrap the day up just really quickly, reminding everyone that we do have a second day. And if we go to the second slide, Wendy, you can see what we're going to do on the second day. And I'm not going to go in depth here, but really we're going to be talking about in session 3A, data-driven drug development tools. And then in 3B, we're going to be discussing how we create regulatory standards for ADPKD. So next slide, please. And so I'd just like to remind everyone about the stakeholders that are online here that are joining the summit. So we have scientists from both pharmaceutical and biotech companies. We have academic basic researchers and clinical researchers. We also have scientists from the health authorities that are joining us, as well as patients and their families. So we have quite a diverse stakeholder group. And one thing I'd really like to remind you about is that really this is a scientific discussion, right? It's not a formal binding meeting. We have regulators with us. They're speaking as scientists, right? They're not speaking for their regulatory agency. And that's something to remember, right? Because if indeed this was a formal meeting, I don't think we could get as deeply into the science as we want to. But this is not a formal meeting. And so remember, the opinions of individuals are their opinions and don't necessarily reflect the organization that they're representing. So next slide, please, Wendy. So we made, as a stakeholder group, significant progress to this point, right? We've definitely pushed the boundaries of both basic and clinical research in the study of PKD, as well as refined drug development science for the therapy of PKD. And we want to go further. right? But I think one thing that we've really learned from interactions across the stakeholder group, especially in the Polycystic Kidney Disease Outcomes Consortia, is that collaboration works, but only with very strong leadership. And that's where I'd like to thank the PKD Foundation, as well as reflect upon the leadership of the Critical Path Institute for helping to lead these activities. Likewise, all the participants, without you and your participation, we would never be able to push forward these frontiers. And everyone has a role to play. But the interesting part is that we all have a common vision, and that's improving the lives of patients with PKD. So next slide, please, Wendy. So with that, I'm going to turn over the summit to Dr. Ron Perrone from Tufts University Medical School. Ron, the floor is yours.
John Michael, thank you very much for the introduction. If I could have the next slide, please. So John Michael has gone through the agenda for this morning. You can see it before you, and also listed are the names of the panel members who we will introduce as we get into the panel discussion. Next slide, please. So we've had 3 recorded presentations, actually 5, 2 from patient families and 3 from speakers on autosomal recessive PKD, clinical aspects, on the AREG PKD registry, translational strategies for ARPKD, and 2 patient and family perspectives. Next, please. And thanks again to the speakers and the patient and family representatives. And just a word, the presentations that have been recorded will be online potentially forever, but for a very long time. Next, please. So ARPKD is a rare hereditary kidney disease that affects between 1 in 20,000 to 1 in 26,500 live births. The perinatal presentation is notable for massive nephromegaly and pulmonary hypoplasia, with a 30% mortality and 40% requiring mechanical ventilation. Kidney disease after the neonatal period is associated with CKD progression at variable rates, and hypertension may be severe. Next, please. And of course, the liver manifestations of ARPKD can be quite severe, leading to hepatic fibrosis, dilatation of the intrahepatic bile ducts, and portal hypertension develops in a subset of patients. Next, please. So I've taken the liberty of picking 3 slides from each of the 3 scientific speakers to highlight aspects of their talks. And again, these are available online as recordings and are not going to go away in the near future. So we know that ARPKD has progression of kidney dysfunction, with on average a relatively slow decline of GFR, about 1.4 mLs per minute per 1.73 meters squared, as shown in the CKID cohort study, and the rate of GFR decline is highly variable. Next, please. We know that this GFR decline leads to not only chronic kidney disease, but kidney failure. And in this slide, you can see the difference between those who presented in a neonatal period, that 25% have kidney failure by age 11, whereas those who present later, 25% have kidney failure by a much later age of 32 years. Next, please. And of course, the liver disease is quite a serious issue for many of those who are affected by recessive PKD. The liver disease is always present histologically, but may be asymptomatic. It can be predominant or co-dominant in some children. Congenital hepatic fibrosis, that is portal tract fibrosis, and dilatation of the intrahepatic bile ducts are serious issues, with the latter leading to a risk of ascending cholangitis. And portal hypertension and its complications, including splenomegaly, leading to low platelets and possibly low white blood cell counts, esophageal and enterogastric varices with a risk for bleeding, and of course, a potential need for portosystemic shunting in 10 to 40% of patients. And finally, liver transplant may be needed in as many as 13% of patients with severe portal hypertension or recurrent cholangitis. Next slide, please. So Dr. Liebau presented data from the AREG PKD registry, and this is the largest registry of autosomal recessive PKD in the world. It's an international registry, and there's close cooperation between that registry and those in Children's National and also in the UK. As of recent date, MAX has included 680 individuals with 3,800 plus independent visits. Next, please. And some of the insights that can be obtained from such a registry are shown on this slide and the next one. So those that Max and colleagues were able to determine the height estimated total kidney volume. And in the blue shading are those kids who have the highest percentile, that is the highest quartile of height estimated total kidney volume in the first 18 months. And you can see that they have a much greater likelihood of developing kidney failure than those who are in lower quartiles of height adjusted total kidney volume. So this is an important insight and may represent a potential prognostic biomarker. Next slide, please. And then Dr. Liebau and colleagues have looked closely at genotype, phenotype correlations. And again, all of this is in the recording, but let me just point out that in panels B and C, those individuals with mutations in the C-terminal portion of the protein, shown by this golden line, have a much more greater likelihood of developing portal hypertension and substantial hepatic complications. And notice in panel A that this same mutation doesn't necessarily lead to the same severity of outcome. Next, please. And Dr. Gay Woodford has nicely outlined for us what's needed to move forward. And I think we've got a lot of that assembled in the speakers, the panels, and the audience today. So we need research-ready patient cohorts, and we have international databases. We have a lot of pathobiological insights, those that are common to AR and AD PKD, and those that are specific to the recessive form of PKD. We have biomarkers of disease progression, although these are largely hopeful biomarkers rather than definitive biomarkers at this point. There's a lot more work that needs to be done in that area. And then, of course, therapeutics. Dr. Gay Woodford has reminded us that drug repurposing is an important idea, as I'll show you in another slide. And of course, the development of novel agents is very important. Next, please. So there are specific pathogenic mechanisms related to cyst initiation and dysfunction, those related to epithelial cells, proliferation being a major factor in cyst initiation, and then much more to be learned about cyst progression. Of course, interstitial inflammation and the role of macrophages is very important. And of course, fibrosis, both in the liver and the kidney, are quite important. Next slide, please. And again, Dr. Gay Woodford reminds us that the PCK rat, which is it behaves like an autosomal dominant PKD model, but it's due to a mutation in polyductin fibrocystin. And this rat, when given inhibitors of vasopressin in the top panel, and or when vasopressin is genetically eliminated by breeding with rats that lack vasopressin, the Brattleboro rat, you can see that in this second from the right panel, the disease is largely ameliorated. And if you give vasopressin back, you fulfill Koch's postulates, it gets much worse. So this is an important consideration. Next, please. So again, all the recordings are available. I'm now going to introduce Julie Marshall. Julie is the parent of 2 children with autosomal recessive PKD and a member of the PKD Foundation Board of Trustees. Julie, the floor is yours.
Thank you, Ron. Hi, everybody. I am, as Ron said, I'm a patient, well, parent of a patient with ARPKD, which everybody listening already knows what that is, or you're listening because you know me and you really want to hear me talk for 15 minutes, in which case you should really know what ARPKD is by now anyway. Um, as the pre-recordings kind of went through pretty in depth, everyone with ARPKD has a really different progression, and we still don't know what to expect most of the time. So I am going to tell you the story of my family and what we have gone through and are still going through right now. About 6 years ago, next month, I had no idea what ARPKD was. We had been pregnant with our second child, and my first pregnancy was super uneventful. Nothing happened. Everything worked out the way it was supposed to. We had very few appointments, very few scans because everything with her looked great. Then we fast forward to having a second baby, and we had our 20-week anatomy scan. We walked in with that wonderful, blissful happiness that most pregnant parents have, thinking we were going to find out, if we were having a boy or girl, and so excited to start buying clothes. Instead, we found out that something was wrong with his kidneys. At that time, we still had no idea what that meant. We were told that they were echogenic and bright and had something else going on, but the tech really didn't tell us much more, so we had to have a few extra appointments to find out more than that. And through those appointments, we found out that the most likely thing was ARPKD. After that, being a researcher at my job, I went to the internet and looked up everything I possibly could about ARPKD. Most things I found did not give us much hope, and then some things I found gave us a little bit of hope. And I found some support groups on Facebook and started talking to people. We then had more appointments, met our first nephrologist, and got to know a little bit more about the disease. Unfortunately, that nephrologist knew very little about ARPKD and gave us less than any hope. We were told that our only option was to terminate because people with this disease just do not survive. Having already talked to people who had the disease, I knew that was not true and that there was a possibility he might survive. So we then started searching for a new nephrologist. We luckily were able to get in with Boston Children's, and we love our team there so much. And we found the team that was willing to fight for us, which is one of the things I recommend to anyone getting this diagnosis now when they come into different support groups, is that you have to find a team that knows what they're talking about, that knows the disease as much as we possibly could, and that will fight for you. Because some nephrologists just are still learning. All of us are still learning, really, because we don't have any idea what's happening. So we then had lots and lots of extra appointments. We got to know lots of different specialists, and it was the most stressful pregnancy I think anyone could ever have. Finding out that something's wrong with your child and that you might not get to meet them, and if you do, you might not get to keep them, is really not anything any parent wants to hear. So we did everything we could, and we kept all the appointments, and we tried our best to get him the best case. And then at 31 weeks, he was not doing super well. He had developed eye drops, and he wasn't going to be able to stay in. So we had to have an emergency C-section to try to save him, and it didn't work. Sorry. So we were then at the point where we had to say goodbye, and it sucks, and it's really hard. And I told myself I wasn't going to cry during this and that I was going to be fine. So,
Julie, you're doing fine. Thank you.
We then had to go home and explain to our daughter what happened and that her brother wasn't coming home. She was 23 months old at that time, so she really didn't understand at all. She didn't understand why he wasn't coming home. She didn't understand fully what that meant. I don't even know at that age if she fully understood what a brother meant, or that like the baby was going to be there originally before we found the diagnosis. So it was really hard to kind of work through our grief while trying to keep her happy and honestly at that age somewhat oblivious. We were trying to make sure that she didn't fully understand that too, because she wasn't old enough to really get it. So we then went through a bunch of stuff trying to find out, what happened. Was it really ARPKD? Why did it happen? It's something we'd never heard about before. So we had no idea, like, are we carriers? Do we have it? Is there something else we have to be aware of for our daughter? And we had genetic panels done twice with no results whatsoever. So that's when we found out that we still only know about, I think it's 80%, it might be a little higher now, of the mutations responsible for ARPKD. And we were just super lucky that the ones we carried were unknown. So the regular panel that they usually run couldn't find anything. We then had to figure out what we were going to do. What does this mean for our family? We now have our daughter, and we have our son, but couldn't keep him. Do we want to have another baby? What if this happens again? What's our plan and what are our options? As many of you, especially the scientists and doctors, know, without that genetic component, we don't really have many options. We couldn't do IVF to make sure that it didn't happen again because they can't find a gene that they don't know, and they can't isolate it and make sure it doesn't happen if they can't find it. So we did more testing and nothing, and eventually decided that we wanted to have another baby. So we did. When we were about 3 or 4 months into the pregnancy, we were accepted into a research opportunity at Boston Children's where they did a full exome sequencing and finally found our gene mutations. We're super lucky, but not, that the mutation that I carry and the mutation my husband carried, neither had ever been seen before. So they were both brand new, which is why they couldn't find anything the first couple times they looked, which is exciting for families in the future. And I'm glad that they found them so that somebody else would be able to have them identified. But at that point for our third baby, it was obviously too late to go through IVF. A couple months after that, we had our anatomy scan, super stressful, and they didn't really see anything wrong. But with our history, we asked them to keep looking. So they kept looking, said, maybe their kidneys are a little bit echogenic. So we had another scan a couple weeks after that and could clearly see that they were definitely full of cysts. They were echogenic. They were definitely bigger than they were supposed to be. And here we were again. So we had to call our team in Boston. We were lucky that we were already patients and able to get back in with our same team and able to start making a plan. We had to discuss all the options. Obviously, they discuss termination, they discuss what to expect, they discuss what may or may not happen, but really they don't know. And our nephrologist was really good about saying, we will fight with you. We will do what we need to do. Here's our plan. Here's what makes sense. Here's what doesn't make sense. But we don't know. We don't know what's going to happen. So we had a very long, very lonely pregnancy. Even knowing kind of what to expect and knowing the worst case scenario and having been there, it's still really hard because nobody understands. You tell people what's going on and they say it's okay, it'll all work out, but sometimes it doesn't. Sometimes it does work out and sometimes it really just doesn't. And hearing that doesn't help. It doesn't make it feel better. It doesn't take any of the stress away. So we didn't really tell many people that we were pregnant until we were about 5 or 6 months in, I think, because we just didn't want to talk to anybody about it. We didn't have any more info to tell them, and we didn't want to hear about it. We didn't want to hear it was all going to be okay if it might not be. So we had our third baby, and actually he is okay. He has ARPKD, and we have a lot of extra appointments because of it, but right now you would never know. He is really happy 3.5-year-old. He is a really very toddlerish pain in the behind some days. But other than our extra appointments and knowing that there's something going on, you would never have any idea that he had anything going on inside. He also has hydronephrosis in both of his kidneys, which they don't think is related to the ARPKD. So we just have lots of super fun appointments related to his kidneys in general, and they just don't want to do what they're supposed to do. So that's been super fun. It's been hard since then, because since he came, when he was a baby was when the grief hit my daughter and when she fully realized what she had missed out when Porter didn't come home and what having a brother meant and why Porter wasn't here. And she had a hard time figuring out what that meant, because at that point she was only 4. She was still young. And at 4, most kiddos haven't had a lot of experience with death yet, and they don't really fully understand the finalness of it. So we had to then go through all of that again, and try to explain to her and teach her, you know, what it means, what happens. And while we have all these extra appointments, you know, that right now her brother's okay. So it's definitely adds a whole different level to when you just want to have babies and you want to have more than one of them. And then you have to always worry and always wonder and not know what's going to happen. When Jamison was about 1.5, he had a seizure while I was giving him a bath. And that was terrifying and would be terrifying for any parent. And then we had the additional worry on top of it that there might be something else going on, that it might somehow be related, because we still don't really fully know what all of the signs and symptoms of ARPKD are and what it's going to look like for him. That seizure lasted 23 minutes and only stopped because he was administered medicine. So we then had a night in the hospital trying to figure out what was going on, and we had to have an EKG to see if he had a seizure disorder. And it was super extra stressful because of all of that. And we had to be transferred to the Children's Hospital, but Boston didn't have room for us, so we had a different team, which is fine. But I always feel better if our team that knows him well is there. And it's definitely hard because they don't always have room. He luckily has not had another seizure since then, and that was about 2 years ago. So that's been really good, but I think it's always in the back of our minds. Anytime that he has a fever, if it's over 102, we have to go and have him pee in a cup and make sure it's not a UTI and make sure there's nothing else going on. So that definitely adds another level to where you wouldn't have to worry about that with a kiddo that doesn't have ARPKD. With my daughter, we don't have to worry, and it's not the same. You know, obviously every parent worries about their babies, but it's really different when you know they're going to be okay versus when you have no idea what's going to happen. Now we have COVID and all this fun stuff we're going through now. We pulled the kids from daycare and have been home for 15 months because of it. We haven't really seen anybody or gone anywhere because we just don't know what'll happen if he contracts it or how he'll fare from it. I mean, obviously none of us know, and it's scary, and the long-term effects are scary, but I feel like it's an extra additional worry for him because of everything else. And there's, you know, most people listening to this probably know there's some kidney damage concerns, and he doesn't really need any help there. So we've been here all the time in our fun, lovely house all day, every day for 15 months. It's been really hard when we have friends that, you know, are starting to go out and starting to do stuff and just don't have to worry about those extra concerns that we do. They don't have to have the same fears that we do. And obviously nobody wants to get sick and nobody wants their baby to get sick, but it's different when it means hospital versus a cold compress and some Tylenol. We have to be careful, you know, when he's out and about and when he's doing things. If he chooses to play sports when he's older, which I really hope he doesn't because we are not a sports family, we'll have to be more careful about making sure he doesn't get hurt, making sure he doesn't, you know, play anything that's really physical like football or anything like that, because he could get much more hurt than his peers could. And it's really, like I said, it's an additional extra level of stress from having a baby or a kid. Even with the anxiety that we all have as parents, it's amped up, for lack of another way to word it. So we have all of that and some extra stuff, but it has been really great having him be as healthy as he is. He hasn't had any UTIs yet, knock on wood. He hasn't had any additional concerns past knowing that his kidneys are not working fully. But, well, that's not fair, actually. He has full function right now, but one day they won't be working fully. And knowing that one day something is likely to happen where he'll need a transplant, we're just hoping that one of us can donate to him at that time so he doesn't have to go through dialysis or any additional stress. And we, in the meantime, just keep a really close eye on both of them and make sure that everything we can possibly have to make him as healthy as possible is in place, and hope that his kidney function holds out until he's much, much older. 3.5 would be a really tricky age to go through surgery or extra hospital stays. So if he can be old enough to understand that, it would be super cool. And that's kind of the hope where we're at right now. Like, we know we can't hope he'll never need a transplant, although that would be awesome. We just have to hope that he's older and understands what's happening to him, and that he understands why, and hopefully can handle it better. I know right now, as Ron mentioned, I'm part of the PKD Foundation Board of Directors, and I have been trying to advocate and spread awareness, and this is the way that I'm currently doing it, is being part of the Board of Directors so I can continue to help the other families that either are already here or aren't here yet, or don't know that they'll be here one day. Hopefully we can try to find a way to get more support, to find more information out. We are currently on the board, just developed an ARPKD task force, which is pretty exciting. And the purpose of that is to include physician scientists that develop things for ARPKD, parents and executive staff members, and to establish how we're going to move forward, what the community and task force is going to work on a comprehensive strategy for research, for a communication plan, and to advance outcomes for ARPKD. So that is my current excitement. I'm hoping that we can do a lot of really good things to help a lot of families, hopefully including mine. But if we help a lot of families and it's, after mine needs help, that's okay too, because it'll still help kids in the future. And I'm looking forward to seeing where we go from here.
Julie, thank you for your extraordinary sharing, and also for your advocacy. Sure, it's very hard to get up in front of an audience like this and let all this out.
I think it'd be easier if I could see them.
Okay, well, we're watching, but I'm an adult nephrologist, and so I don't deal with the crises that I'm sure you and many other ARPKD parents deal with on probably a daily basis. So Dr. Gay Woodford will just, who's a pediatric nephrologist with great experience in ARPKD, I just asked her to weigh in on her, from her side of the fence, how she sees other families and your family's story play out.
So Julie, thank you. That was very courageous of you, and I think very helpful. The difference between what happened with Porter and Jamison's course is common to patients that have the sort of classic form of ARPKD, because it's common in recessive diseases. Siblings don't necessarily get a playbook, in utero, and okay, so your older brother or your older sister had this course and you're going to follow it. And that makes it so difficult. Difficult in the order that your children were born, difficult for different reasons when it happens in the reverse order. So I think it's a very important lesson, that there is so much that we need to know, even among children who are carrying the same mutations. I wonder if you could talk a little bit about the importance of the support groups, because although Porter and Jamison don't have defects in the most common gene involved in ARPKD, there are a whole group of diseases that look like ARPKD. And I know that families that have children affected with defects in those genes are part of the support group. And there probably are common themes in terms of kidney-related issues, liver-related issues. And so how, because this seminar is being, or symposium is being viewed by a wide variety of people, can you speak about the importance of those peer support groups?
Definitely. They helped a lot. I think at first it gave us hope. We were told, like I mentioned, we were told that there was no hope, that Porter wouldn't make it. And though that was true for him, it wasn't true for Jamison. And having those support groups, there are people who have children on dialysis, there are people who have children who didn't make it like Porter, and there are adults living with ARPKD and Adpkd. And it helped to know that it was possible and that it was worth fighting for. It made a big difference when you're already super hormonal and everything else while pregnant, hearing that there might be hope helps a lot. Hearing what to expect, what questions to ask, what to look for in a nephrologist, all of that stuff was really helpful. I've never really looked for a specialist before. I've never really had super concerning things where it mattered who my doctor was, for lack of another way to word it. My doctors have always been fine. They've handled what I needed. I haven't had anything super in depth until this. So I really had no idea how to shop for a doctor, if that makes sense.
Yeah.
I had no idea how to know when they weren't a good fit, because mine always just had been, and I had been lucky there, and that is not everybody's luck. But I didn't know what to do. And the support groups helped a lot with that. When we didn't find out the genetic components and we came back with nothing, the support groups helped a lot with that too, just to remind me that, you know, it doesn't actually really matter in the long run. We look at the symptoms that are occurring, we work on those, we treat them in a way that's appropriate to him and to the symptoms, versus this is the mutation he has and this is what will happen, or this is what we do. Really, it didn't matter that we didn't find it. It just mattered because we couldn't do IVF, and we decided against that anyway for a whole host of reasons. So it's definitely, it was my go-to, and it still is a lot of days. And I try really hard to answer as many questions of other people and help support them as much as I can in there.
So thanks. My question was because I've heard from so many families stories that are very similar to yours in terms of the importance of the group. And I think that we very often focus on the care teams in terms of helping patients and families cope with this rarer PKD. And I think that one thing that we need to think about is how important the support groups that, for example, the PKD Foundation, the ARPKD CHF Alliance support and promote, because that's a dimension that care providers don't walk in your shoes, and we can't provide it in the same kind of way. So thank you for being so eloquent about that level of support.
Thank you, Lisa, and Julie, thank you once again for sharing your family's story, and we greatly appreciate that and your advocacy. We're going to switch to the panel discussion now, and I think, Julie, you stay on. I'm going to ask all the participants and moderators in the panel discussion to turn on your cameras, and please join us. Reminder to the audience, submit all questions for panelists through the Q&A function, not the chat function. And we have a bunch of things we've already decided to talk about, but we want to also open to the audience. So if there's things that you don't think we're covering, again, use the question and answer function. So just brief introductions. I'm Ron Perrone from Tufts Medical Center. We'll just go down the list. Lisa?
Hi, I'm Lisa Gay Woodford. I'm a pediatric nephrologist from Children's National.
Catherine?
Hi, I'm Catherine Dell. I'm a pediatric nephrologist and researcher from Cleveland Clinic Children's.
Dave?
Hey, this is Dave Eisenhammer. I'm the Vice President of Clinical Sciences at Catalyze Pharmaceuticals, one of the companies developing drugs for both ADPKD and ARPKD.
Aram, one of our speakers.
Hi, I'm Aram Hartung. I'm a pediatric nephrologist at the Children's Hospital of Philadelphia.
Max, another one of our speakers.
Hi, I'm Max Liebo. I'm a pediatric nephrologist at the University of Cologne in Germany, and I'm both a clinician and a researcher.
And Julie, you've just introduced yourself quite well. Anything to add?
I'm not a doctor, but I'm just gonna, help as much as I can.
You probably know more than the average community nephrologist about ARPKD.
Trying.
Yes. Okay, Dr. Mistry.
Hi, I'm Kirtida Mistry. I'm a pediatric nephrologist, and I'm a clinical reviewer in the Division of Cardiology and Nephrology at FDA.
Thank you. Dmitry Rusinov.
Hello, I'm a pediatric nephrologist from Sofia, Bulgaria, and also a member of Pediatric Committee of European Medicine Agency.
and Joe Turner. Maybe on mute.
Hi, I'm Joe Turner. I'm an adult internist and director of the Division of Hepatology and Nutrition at FDA.
Thank you, panelists. Remember, questions go through the Q&A function, and then if we could have the next slide, please. So, as I said, I'm an adult nephrologist, so looking at the great talks that were given and reading about this, with Lisa's help, we came up with this suggestion. I'd be interested in the response of the panel to this. I see autosomal recessive PKD as 3 different diseases. The prenatal presentation, where there's an interplay between nephromegaly and respiratory insufficiency, kidney disease after the neonatal period, and issues related to slowing PKD progression. And of course, the liver disease and the subset of patients who progress to clinically significant portal hypertension. And patients may present with any one of these or combinations. So have at it. We can perhaps just go down the list of the panelists. Lisa, do you want to take the first shot, or I think Catherine is.
I actually was not going to, since I did these questions with you.
Oh, okay.
But just to sort of set the stage. So what we were trying to accomplish here was to get a sense of how do we think about ARPKD? You know, there is an invariable involvement. If you have kidney disease, having liver disease, there's a small subset of patients that have only the liver disease. But by and large, it is a dual organ disease. And it has, you know, 3 sorts of sets of remarkable presentations. We just heard very eloquently from Julie Marshall about the perinatal presentation. And we as clinicians know that there's a lot of consideration and concern about the size of the kidneys, the function of the kidneys, the level of pulmonary development, and the related respiratory insufficiency. So that's one very worrisome group. Then there are the children who have kidney disease and survive the perinatal period. And, you know, as Erin so lovely, so well described in her talk, that there's a very variable course for those children. How do we think about those children, particularly with the mindset of how can we think about interventions that will attenuate the progression of their disease? And then, you know, as we and others have reported over the past 20 years, while liver disease and the ductal plate malformation is an invariant finding in ARPKD, there is a subset of children that progress to clinically significant and sometimes clinically remarkable portal hypertension that can require very heroic efforts up to and including liver transplantation. So if these are sort of 3 presentations, does this sort of cover the waterfront for the purposes of this discussion in thinking about how can we move forward to clinical trials? The group in the perinatal period, the kids with kidney disease that are progressing, the kids with liver disease who progress to significant portal hypertension. In the second group, how do we think about their liver disease? In the third group of the kids where liver disease is really a significant clinical concern, you know, how do we think about trials that may also take into consideration their kidney disease? So that was the framework that we came up with for this discussion.
Thank you, Lisa. So just going down the list, Catherine, then Dave, then Aram.
Yeah, so I think that certainly clinically, these are kind of ways we might divide it up. I think from a clinical trial standpoint, you know, there is considerable overlap in some of these. So for instance, you know, there are patients, as we all know, who are diagnosed prenatally, but don't have the oligohydramnios, don't have massively enlarged kidneys. You know, had there not been high quality ultrasound, they might have been diagnosed when they were 2 or 3. So I think that perhaps, and similarly, there are kids who have liver involvement and the liver involvement becomes more prominent and they may coexist equally severe or one more than the other. So I guess when if I'm thinking as a clinical trialist, obviously we want kids in a trial to sort of look similar. And so I think trying to identify subgroups that are at risk for progression, but perhaps are not so at risk for progression that they're challenging to sort of capture in the moment would be, from a clinical trial standpoint, probably the best group to focus on initially. But again, the ones with the prenatal presentation are also the most severe. So they also, if they respond, it would be sort of amazing. So I think it's just, there are some challenges, and I'd love to hear what the rest of the group says.
Do we want to jump? Let's see, Aram, and then Max, and then.
Thanks, Ron. Yeah, I agree with everything Catherine said. I think it's obviously a spectrum, but I think even it is somewhat helpful to think about these different groups, even in terms of what the goals of a trial might be and how you might think about endpoints differently. So, and I think this brings up the importance of having really good ways to kind of classify patients in terms of a risk level. Because, you know, if you have somebody who is at very high risk of progression to kidney failure within the next couple of years, in a group like that, particularly if it's a very young child, being able to delay dialysis or transplant by 6 months, that might be a really big deal, because it is very different to, say, transplant an 18-month-old than a, 2 or 3 year old. And whereas, in the group of people who progress more slowly, maybe your goals might be different and your endpoints might be different. But I think, again, because of the interplay between all of these things, I think it is important for any trial to not ignore the other pieces of it. So, obviously kidney disease progression is a super important endpoint, but I think liver disease progression is also important. And I think trials and, any drug, because all of these things are mediated through the same pathways, any drug by definition is going to be affecting everything. So I think it also is important that any trial measures the impacts of, in both the kidneys and the liver.
Max?
Yeah, I guess I can just echo what has been said. I think it's really important to differentiate also between the different goals that you may be aiming for. So as Catherine has pointed out, it may be very important, to look at patients with the slowly progressing disorder. There you might look for GFR loss. But then on the other hand, there are these kids, as Aram has mentioned, that are severely affected and that might have the greatest benefit from a very early intervention, and identifying these different subgroups and sort of establishing something like, as Lisa has pointed out in her talk, a risk score for ARPKD. This is, I guess, a major would be a major step ahead. So trying to bring these little pieces of the puzzle together to understand who is at high risk of either of the three diseases that you've listed on this slide would be a crucial step.
Thanks, Max. Julie, anything any thoughts on that?
And I don't really have anything to add. Right now, we don't have any liver concerns for Jamison, but we're obviously keeping an eye on it.
How would you feel about enrolling Jamison in a clinical trial?
It's definitely something we would be looking into. We enroll him every time we go to the doctor. There's some research going on, and we've enrolled him in multiple. I do non-medical research for work, so I understand the importance of it. And we pretty much enroll in anything that isn't going to pose a risk to his kidneys. If they need to take one extra blood sample or something like that, we just sign all the papers. And our nephrologist basically knows now that we will still listen to all the stuff they have to tell us for informed consent, but we're going to sign anyway.
Thank you. Let's see. We have three participants from regulatory agencies. Dr. Mistry, Dr. Bissinoff, and Dr. Turner would be interested in your perspective on this as it impacts clinical trial design.
Okay, so
Dr. Mistry is next in the list, but just to keep the audio clear.
Hi, thank you. This is Kate Mistry. So, you know, I appreciate that this is a challenging issue, that, you know, these issues that were raised by Dr. Gay Woodford, Dr. Hartung, Dr. Liebau in their talks about presentations being variable, about clinical costs being variable in ARPKD. You know, these are challenging issues when it comes to selecting patients, trying to identify a population that's at risk for progression, that could benefit from treatment and be studied, as well as selecting endpoints for clinical studies and trials. You know, I think it's great that we're having this conversation. I think it's important that we share information to kind of move forward in this field. And also want to just share that, you know, while these problems seem daunting, that, you know, other rare diseases, you know, have similar issues where natural history is not, you know, fully understood or defined. And I think, you know, it's important that we address these gaps in knowledge and recognize them. And we certainly are excited and happy to work with you to be able to address these issues.
Thank you very much. Dr. Rusinoff?
okay, so from a regulatory perspective, I think, yes, this is a complex disease with 2 organs involved, but if we do clinical trials in 3 different populations, it could be not easy to assess the benefits from some medical product, because if it's mainly for treatment of kidney disease, we don't know to assess the impact on liver disease, and in terms of safety also there could be some issues, and vice versa. If some product is mainly to treat liver disease, we need to see safety or some effect on kidney disease. So it's not easy, and but in my view, it's better to investigate the disease like itself, and of course there are different populations, of course.
Thank you. Dr. Turner?
Yeah, for 1 year I've been the director of the Division of Hepatology and Nutrition, and I've been in other areas of FDA and adult infectious disease trained as well. And in any drug development, an assessment of the liver is done as a safety endpoint. And so from the approach to clinical trials, at least right now in 2021, you could make the argument to go ahead and do extensive liver evaluation in any trial of enrolling children with this disease, in terms of measuring transaminases, getting non-invasive imaging of the liver, and go from there and challenge FDA, challenge us as regulators that these safety endpoints are important to be considered as potential efficacy endpoints. Because one thing that's new to me is now considering liver related endpoints in clinical trials. They're now efficacy endpoints and not just safety endpoints. So I think from that perspective, it's an important consideration. I was very excited to hear in Dr. Hartung's talk about the work done on magnetic resonance imaging, because that, and there's a lot of work done to try to identify a non-invasive biomarker that is clearly associated with liver fibrosis. And so magnetic resonance imaging is an important technology that could, among other technologies that are being evaluated, but I was thrilled to hear work done that children will not have to be sedated in order to obtain the result, because it therefore would represent a procedure that's not greater than minimal risk, and therefore would not pose a problem in clinical trial enrollment of children, where we don't want to offer procedures and events that happen in the clinical trial that are beyond minimal risk. So I was thrilled to see that part in and that work and research being done. So I think for 2021, enrollment of a clinical trial certainly include a thorough evaluation of the liver, even from the context of safety endpoints, but then challenge FDA, challenge us to start to think about these as efficacy endpoints for a new drug development.
Thank you. I've had Wendy advance the slides. You know, I think we've talked about the, let's see, if you could actually move on one slide, Wendy, sorry. Okay, so we talked about the 3 diseases framework, and then one question which would be, I think, highly relevant to development of therapeutics are pathobiological mechanisms for each of the 3 diseases, in parentheses, quotes, known, and are there pathobiological mechanisms in common? And along with that, should liver and kidney disease be studied in the same individuals or in separate populations? I mean, there's a hint from the work from the Dr. Liebau's registry that the genetics of severe liver disease and kidney disease are perhaps a little different. In terms of those of you who have investigated pathobiological mechanisms, perhaps you can weigh in. I think Lisa, Catherine, and Aram and Max have, I believe, done that.
So Ron, I would offer as a sort of a starting point, in terms of common pathobiologic mechanisms versus different mechanisms, you know, there are some hints from genetics. And so our group, other groups have looked at modifying gene kinds of approaches and found that there are different areas of the genome that seem to be modulating disease severity, at least in experimental models, disease severity in terms of the kidney versus disease severity in terms of the liver. But I go back to the point that I think that it's going to be a combination of common mechanisms and specific mechanisms. In this case, in a single disorder, common mechanisms common to kidney and liver, and specific mechanisms specific to either the kidney or the liver. And we should probably keep that in mind as we're thinking about clinical trials. So for example, a clinical trial in newborns who are presenting with very, very severe disease would probably be a short-term study, but there should be consideration about how will we capture long-term data 4, 5, 6 years after the study is complete, not just in terms of their kidney, but also in terms of their liver progression. I think that's important. I think the second thing that's really important is another genetic clue that should be capitalized upon in the lovely work from Adpkd, showing that where genetic defects are situated in the linear expanse of the gene seems to portend what kind of course you're going to have. I think it's important for us to consider building genetics into our clinical trials.
Thank you.
Ron, can I
So I've had Wendy move the slides because we're starting to get into this next slide already, but go ahead, Catherine.
Yeah, I just wanted to comment. So this issue of liver and kidney disease separately, certainly the endpoints for efficacy, et cetera, are going to be different depending on kidney and liver. But I'd also like to turn that question and say, um, is it acceptable from a regulatory standpoint and a pharma standpoint to have children with known liver disease in kidney disease trials and vice versa? Because I'm a little concerned that if we say, okay, we're just going to look at the kidney disease, well, we don't want the liver to get in the way and the toxicities and whatever. Suddenly you have a clinical trial like many of our pediatric clinical trials that takes 15 years to enroll enough patients. So I just wanted to hear from the regulatory standpoint and the pharma standpoint, would you be amenable to actually having children with these disease forms in a drug trial that is only looking at either kidney or liver?
Please, whoever wants to take that, go ahead.
I would be happy to comment on from a pharma point of view. I think drug targeting is obviously something which is very difficult to do in ARPKD. The targets that have been identified for ADPKD often don't carry over to both a liver and kidney endpoint. And so I think that absolutely, I think if we take a look at a drug that may have an impact on kidney growth, for example, I think we have to be willing to enroll patients that have liver involvement as well, not knowing if there would be a similar impact on liver. And I think from a regulatory point of view, obviously safety becomes paramount there, because if we do see a patient that develops transaminitis in the trial, we need to make sure that that's not attributed to the drug, that it's more a disease process type adverse event. And I think it's very difficult because we're all concerned about safety when we do pediatric clinical trials, especially. And I think it becomes a challenge when we have something. I have a question just to go off just a second for the panel. And that is transaminitis a sign of ARPKD liver involvement?
No.
Okay.
So just very quickly, because all of us will jump right in, because we always say to our patients, the liver is probably 95% hepatocytes. That's where the transaminase issue comes in. The ARPKD affects that 5% of the liver that's cholangiocytes. And so very often these kids can have terrible portal hypertension, and their, quote, liver function tests are normal. And so I thought that that Joe's point about, could you just roll into a kidney study all these things to look at the liver? If you're thinking about the liver the way particularly adult hepatologists think about the liver, you'd be in the wrong ballpark.
Mm-hmm.
Yeah, the next slide, don't change the slides, but the next slide asks the same questions for the liver. But let's talk about these endpoints. And in addition, I think a question from Dr. Chapman about what do you do for controls? Do you have to control these trials of this terrible disease? How are you going to enroll anyone in a control-based trial?
That'd be a great question for Max, given the large cohort of ARPKD and the fact that many of the contributors for that cohort come from the ESCAPE trial, which is another huge study in Europe, and also because we all know, at least Aaron, Catherine and I know Max is so thoughtful. Max, can you take the first crack at addressing that question about how would you, let's step it back, not talk about controls, but let's talk about how you design a study. Say, looking at kiddos, let's just pick one of these groups with perinatal disease. What would be the considerations that you would put into study design?
Yeah, I think it's a very, very crucial question. I think so. My thoughts about these young kiddos with a perinatal presentation would be that kidney disease in many of these kids will be the leading phenotype. So they, most of these kids, of the severely affected kids, and these are the ones we're talking about when considering including them into a trial because of safety issues and other obvious reasons of, for any pediatric trial. So the severely affected kids will at this very young age have the lung problem and the kidney problem. Now, we do not really understand the pathobiology of the lung at all. So let's keep that aside, or put that a bit aside. So let's focus on the kidney. So for the kidney, I would what we did in the registry is we looked if there was a high risk group that required dialysis early in life, in the first year or in the first 3 years of life, and we found some easy to obtain sonographical markers that correlated or were associated with that risk. So I would personally go for a high-risk cohort that would also have the biggest potential benefit of such an early intervention. And as Aram has pointed out, gaining 6 months or a year makes a whole lot of a difference for these kids. So in most centers, at least in Europe, kidney transplants will be performed by the weight of 8 to 10 kilograms, something like that. And that means that most of these kids will be about a year and a half or so. They grow a bit slower than normal kids because of all the problems they have, and gaining a bit of time and weight thus and growth for these kids will make it much easier to go for transplant, etc. So this would be a cohort that I would be aiming for. Now for the control question, we're talking about a rare disease. So coming up with the power to do a randomized controlled trial with a placebo arm may be a huge challenge, and here again the question would be to the agencies what you would consider the adequate controls in such a situation with a rare disease, and now talking about a high risk subcohort of a rare disease.
Thank you very much. So Dr. Stockbridge is in the audience, and at PKDOC, we've talked with him about trials that look both at liver and kidney, and I believe he's been unmuted. Dr. Stockbridge, are you able to comment at this point?
Yeah, I'm happy to do so. I think it's important that you address these questions in the right order here. You need to figure out what a reasonable endpoint is, that's feasible, that your treatment's likely to do. I think it's perfectly reasonable to have patients who have both manifestations of the disease. Even if you think your treatment may only affect the renal component of it, there's going to be a concern about whether or not you've got adverse effects on the other. So that aspect of it, I think, needs to be addressed. And then, whether or not, you can rely upon some historical control depends on how well you understand the behavior of the endpoint. If you've got good data that say, GFR declines progressively and a treatment that maybe improves GFR over some reasonable period of time, that speaks, that's sufficient. There aren't many endpoints that have that property, but I don't think it's off the table for this kind of setting.
Thank you.
And can I just make a quick comment? I think the other thing that is a challenge is the heterogeneity of the patient populations in both dominant and recessive polycystic kidney disease. Creating a true matched control group is very difficult because it's very difficult to select patients that may represent similar patients to those that are being treated. However, I say that, and at the same time, I think it's very difficult to interpret data in polycystic kidney disease without a control group. So it puts us in a difficult situation because it's so hard, and the heterogeneity of polycystic kidney disease seems to get greater and greater every year, right? We seem to learn that there are more genetic mutations, that the patients present so differently with both ADPKD and ARPKD that creating a true scientifically rigorous matched control group is near impossible. And at the same time, it's so difficult to interpret the data we collect in the absence of such a group. So I just bring that up as a challenge.
We have, with the registries, we have more than, I think, 800 or 900 individuals that have been studied over time. With, genetics and kidney volume progression, et cetera. So we have a robust historical control database. Go ahead, Lisa.
I'm just going to say two things. So we do have a database of kids that are genetically defined. I think that's really important. I'd like to actually use this as an opportunity to make 3 points. Number one, Julie cautions us. There are mimics of ARPKD, and they involve genes that we know well, like PKD1 and HNF1B. And in our pediatric nephrology divisions, we probably have at least as many patients with PKD1 mutations or with HNF1B mutations as we do in the classic genetic form of ARPKD. So genetics is important here, and control groups might need to take that into consideration. Another thing to take into consideration, and that's why I sort of passed the ball to Max, is we have large registries in the world of kids that have very early onset structural kidney disease that's not PKD. And so thinking about, are there common pathways for progression regardless of what causes you to have cystic kidney disease? Or is it really disease specific in terms of these genes and the pathways in which they operate? We don't know that, but that maybe should be a consideration. And then the final thing is, it's very hard, particularly in the kiddos that have very severe disease, to be thinking about doing the classic randomized control trial, because these families are desperate. I mean, Julie talked in an incredibly compelling and eloquent way of the horror these families go through. And honestly, I can't imagine any of us trying to approach these patients about the classic RCT in a child that's just been born and is desperately ill. So there are lots of things to consider, Dave. Genetics, controls, should the controls be kids with other forms of early onset cystic kidney disease? And we need to have, and what I was trying to tee up, we need to have creative ways to think about study design, because RCT, particularly for the most rapidly progressive, the most devastatingly impactful forms of the disease in the perinatal period, that's just not going to be amenable to an RCT. Max, does that make sense to you?
Absolutely, I fully agree, and I think there are some fields emerging. I know that the EU is now supporting research on new statistical approaches for rare diseases. So there has been the setup of these European reference networks on rare diseases, and attached to these, there's funding for new statistical workup, as you've been saying, going beyond the classic RCT. I think this ARPKD could be a disease that could be interesting for such approaches.
Dr. Mystery has a comment.
I think this is a challenge. This is particularly a challenge when you're dealing with the disease in young children that can have a very severe presentation and outcome. I think that, what you need to address and what we need to use these registries for is to really try and define the natural history, try and identify this population that's going to be at risk that we can, target for therapy, for measuring outcomes in clinical trials. And then the other issue I wanted to bring up, and I'd be very interested to hear from Julie and parents, patient advocates about the things that are important to them and their tolerance for this question about whether they would be willing to be randomized or have their child be randomized to placebo or an active, some other control arm. Because ultimately, what we want is we want to have we're looking for sufficient evidence that a specific treatment is effective and that we can use it, in that context.
So would orphan designation be useful in this context? I recall, Lisa, you remember this. Melanie Blank spoke to a group of us at Pediatric Consensus Conference about orphan drugs and pointed out drugs that were approved based on 12 patients using only historical controls. I don't know, and I don't know the rules in Europe or Canada regarding those very rare diseases, but I wonder if there's some way to help advance this.
This is Joe. I could just comment briefly on the orphan drug designation. It doesn't, having orphan drug designation, it doesn't take away our statutory requirements to demonstrate efficacy. And so that statutory requirement is still there, regardless of whether there's orphan drug designation or not. I mean, the orphan drug designation does have other benefits associated with it, but from the evidence of efficacy standpoint, it doesn't have an effect on that. You still have to establish efficacy. Now, that said, I can tell you that I don't mind sharing with you, most companies that from the start come in with a historical control trial design for their phase 3. We always try to direct them away from that and into a concurrent either active controlled or placebo controlled trial. But that said, our law, our Code of Federal Regulations describes adequate and well-controlled trials, and the historical control trial design is included in that definition of an adequate and well-controlled trial design. And are there examples where FDA approved a drug on the basis of historical control? Absolutely, there are examples out there. And the example that's given in the law is that the historical control, the natural history of the disease course, there is an endpoint or an outcome that's so severe, that's so large, that the single-arm historical control trial design is useful and can clearly ascertain efficacy. And the example that's given in the Code of Federal Regulations is a disease process that has a very high irreversible morbidity or mortality. And therefore, if an open label single arm historical control trial design can show an effect of a low level of irreversible morbidity or mortality, that's appropriate then for historical control. So we're certainly open to discussion about that and flexibility with phase 3 trial designs, and we understand this is a rare disease area, and that the randomized control trial design is going to be problematic, to say the least. And offering, we also have to be mindful of the Code of Federal Regulations 5050 to 5054 that allows for protection of children enrolling in clinical trials, and offering the prospect of direct benefit and not having greater than minimal risk, those things are important for clinical trial design. And so it'd be interesting to hear from other pediatricians whether they think that placebo control might be an acceptable trial design here, or whether that's off the table because of, offering the prospect of direct benefit and so on. It'd be interesting to hear that discussion.
I would just throw out that those that are born with massive kidneys with respiratory failure would fit the historical control where a lot of those kids end up with kidney failure or die. And I think Max and others weigh in, but I think the evidence of the database to support that is extensive.
Ron, can I just make a comment about the early onset disease? I think it's important to highlight that the babies who die in the first month of life die from respiratory disease. They usually don't die from kidney disease. We often are able to do neonatal dialysis. So it's an important consideration that we're probably not talking about actually giving a drug when they pop out. We're talking about seeing if they survive that first month or so, and then take all the data that Max has about the high risk, et cetera, and the massive kidneys and time to dialysis, et cetera, and those would be the population, but we're not talking about the first month of life. Lisa and Aram can weigh in on this, and Max.
Yeah, I just want to comment about the historical controls versus concurrent controls. Given the variability of the disease, I also don't think concurrent controls really help you that much, right? Like you could have someone who's recruited in the same trial, but if they don't match the characteristics of the enrolled patients, then that control also is not informative. So I think the key for any trial design in ARPKD is going to be expanding on like the work of Max and others to really define panels of things that we look at to really define a patient's risk. Right. So whether that's a combination of genetics, imaging characteristics, historical factors, urine or blood biomarkers, so that we can basically separate people into, okay, you have these biomarkers, this is your expected trajectory. And then you don't need concurrent placebo controls because you have defined the characteristics of a certain population. And then just to quickly comment on the whole liver versus kidney thing. As a nephrologist who studies a lot of liver biomarkers, I strongly would advocate for any trial to consider both liver and kidney because it's impossible to separate those things out cleanly. And it's a very rare disease. So the chances, you're never going to find, okay, I want this perfect patient with just liver involvement and no kidney or vice versa. So you have, these are humans who have livers and kidneys, and we need to consider the entire package, both in terms of efficacy, but then also in terms of safety. And then just one final point is I think the really other important thing is going to have very strong and clear safety endpoints, safety stopping rules and everything in these trials, because look at the drugs that we are looking at that look great in animals. These are drugs that essentially do things like affect growth factors and cause a state of diabetes insipidus in young babies. And these are things that have the potential for significant toxicities. And so you have to really have very clear safety parameters around all of these things, particularly when you get into the very young babies, because if you give someone that makes them stop growing or makes them dehydrate or whatever else, then you're just not going to be able to move forward.
I think Lisa had a comment about biomarkers, but could you also address the issues of transaminases? There have been several questions that have come up regarding liver toxicity and such.
So so let me do the second question first. So the typical transaminase profile reflects hepatocyte injury. Interestingly, hepatocytes are one of the 4 cell types in the body that don't express primary apicalcilia in terms of an epithelial cell type. And they are not damaged in a primary way in ARPKD. They can be a consequence. They can be a sort of a secondary consequence of severe cholangitis, for example, that you can damage the hepatocytes. The ARPKD target in the liver is the cholangiocytes, and they do express primary apicalcilia. And we have relatively few clinical markers in terms of blood studies, for example, of damage to cholangiocytes. One of the things that many of us use, it was originally reported by Moral and Gane at NIH, is using GGT because it tends to be an enzyme that really is more cholangiocyte specific. But I think that it would be a mistake to think that we're just going to pick this up, as I was saying in response to Joe's point, looking at a transaminase profile like as part of a REMS protocol, looking at transaminases, because that would be the effect of the drug. That's not a consequence of the disease. I do want to sort of segue from that into biomarkers, because there have been just a lovely set of comments in the chat. So first, let's start prenatally. Are there prenatal markers? Well, the first, which was for a long time held forth as a prognostic marker, is the level of amniotic fluid, whether it's the total amniotic fluid or single pocket amniotic fluid. And we as pediatric nephrologists have all taken care of children who have had oligohydramnios to the point that there was very little amniotic fluid. One could even say maybe it was anhydramnios. And some of these children have required very minimal ventilatory support for reasons we don't understand. And there are children who have oligohydramnios, as Catherine was pointing out, who actually have some amniotic fluid, but have a really incredibly aggressive perinatal course and end up dying in the first 24 to 48 hours of age. So then Arlene Chapman asked, I think, a very thought-provoking question. Well, has anybody looked at markers within the amniotic fluid? Again, somewhat difficult in a disease where amniotic fluid tends to be reduced. To my knowledge, nothing has been done in terms of a proteomic assessment of amniotic fluid. One place to maybe think about posing this question is with the RAFT study at Johns Hopkins, where for children who have significantly decreased amniotic fluid before 26 weeks of age, a whole variety of causes, that they go in and do amniotic fluid infusions. And it would seem to me, as part of the procedure, that they could potentially build in a way to extract a small amount of whatever fluid is there before they put in the saline that is part of their protocol. So those are certain strategies. I think if we go beyond the beyond the natal period into the neonatal period, when we look at markers that are blood or urine markers, whether they're the classic markers that everybody looks at for kidney injury, MCP1, NGAL, beta-2 microglobulin, some of the inflammatory markers. In childhood PKD, they have not been sort of remarkably promising. Not to say that they're not promising, but those kinds of classic urine or well-established urine and blood markers don't seem to have at least the initial blip on the radar screen to say that they might be useful. I think that's part of the reason that in this part of the symposium we've so strongly emphasized imaging biomarkers. But again, I would add to that genetics may actually be able to give us some prognostic information, or not prognostic, predictive information about what disease course might be. And that's part of the reason to be thinking about a sort of a holistic approach of combining different markers into sort of a prognostic score, the way that Emily Legal-Kernack did for Adpkd. I think it is a really complicated kind of approach. I'd say one final thing, because I think Joe wants to say something. One final thing is that, I don't think it's clear what's the right study design. And I think that one of the things that this community would be well served by is to have a really careful think, not just among the people who take care of these patients, but also methodologists is what I'm trying to say, who really think about study designs to be applied to this group, and that's particularly true if we're thinking about children in the newborn period, where so many of them are desperately ill.
Thank you, Lisa. This conference is certainly the first steps toward that. I believe Dr. Turner, then Dr. Mistry.
Just a few things to say about biomarkers. First of all, the letters of intent for biomarker qualification are available in the public domain, and you can see there's a robust interest in trying to identify liver non-invasive biomarkers to assess to assess liver fibrosis and so on. So there's a robust qualification effort in that regard to identify a biomarker. But I wanted to sort of challenge you all on biomarker development. Some of you may recognize my name. I was the FDA liaison to the critical path to TB drug regimens, and I pestered the working groups. It became quite annoying to them, but I pestered the working groups about biomarkers and in terms of TB drug development to ascertain culture negativity as not just a biomarker, but more than that. And the academicians and industry listened to what I had to say. They published in peer-reviewed journals the correlation between culture negativity and clinical outcomes of cough improvement, lack of sputum production, weight gain, these things that are important from the patient's perspective, because we were getting criticism of accepting only sputum culture negativity as an endpoint. The critical path also instituted a data standards. And so we had large trials from the Centers of Disease Control and Prevention that we were able to review culture negativity and verify that it translated into what was important from the perspective of the patient, which is improvement in sputum production, resolution of cough, weight gain, and so it was very important work for us that through the critical path that the biomarker of sputum production, sputum culture results was actually the clinical endpoint of how a patient feels, functions, or survives. And I think that is very helpful for drug development because it's not just a surrogate endpoint. It is at the early month 3 or month 4, it could be a surrogate, but then to follow patients for years to ascertain how they feel and function, that could prove to be a very difficult in drug development. And so having a biomarker that's the clinical endpoint, similar to HIV viral load, hepatitis C viral load, those are the clinical endpoints. And I guess I would challenge you all to think along those lines, not just in the context of surrogate endpoints. If you could provide evidence for us, and we can't, we react to scientific data that's out there. If you could help us with this issue of biomarkers of being not just a surrogate endpoint, that's important too, and that work should be done. But if you could translate that into a verification of how a patient feels, functions, or survives, if you can do that, that would be huge in this development field. I just wanted to put that plug out there for biomarkers. Thanks.
Thank you. We happen to have had a slide that we hope to talk about, and thank you for doing that. I think Dr. Mistry had a comment about safety.
Yeah, I really do, want to reinforce what Dr. Turner just said about endpoints and clinical outcomes, to really encourage the community to kind of evaluate those outcomes associated with new and novel biomarkers as they're being developed, because that, as regulators, is important to us, especially in diseases where you can't necessarily measure a clinical outcome within the course of a clinical trial. The other point I wanted to make, just going back to what Dr. Hartung said about safety monitoring, and also just going back a little bit to this issue about placebo controls or concurrent controls. I do think it's really important that we place families and patients at the center of those decisions. I think safety monitoring obviously is very, very important. There can be, measures that can be put in place when a trial is being designed with regards to stopping criteria, etc., to protect patients in clinical trials. But I think we also, while we need to make sure, obviously, that trials are safe, we also need to think about, the burden of monitoring and balance that, within the lives of patients and families who already have a lot to deal with. So I think we should think about that. The other issue I wanted to raise about controls, specifically about placebo controls, again, just putting it out there, is to think about, what families would tolerate and what is acceptable to them, especially in a condition where there are no treatments, there are no options. How can we get the information we need in a way that will be meaningful? I also want to, we could think about things like, if there were a placebo arm, would it be acceptable if after a certain period of being on placebo, whether then patients could all transition to active drug if it was, possibly beneficial? And the other thing also to think about is, there are measures, just like we can for safety, there are measures that can be put in place for efficacy analyses with interim analyses that are pre-planned, such that if there is overwhelming evidence of efficacy, all patients can then be transitioned to an active drug.
Thank you very much, Dr. Mistry. I've had Wendy advance the slides to clinical trial design in liver, and I think one of the bullets I wanted to make sure we cover is prognostic enrichment, not only for liver, but also for kidney. In autosomal dominant PKD trials, we use the Mayo Imaging classification now to select for a risk of rapid progression. And we have some characteristics from the PKD registry that suggest some items to look at. Are there other ways to enrich? Any of the clinicians, Max, Aram, Catherine, Lisa?
Yeah, I think in terms of the work we've been doing in the liver, one thing could be some, these measures of liver fibrosis with these non-invasive elastography methods to measure liver stiffness, because certainly in our studies with both the ultrasound elastography and the MR elastography, we saw that the children who have ARPKD, that their numbers were higher than healthy controls, even if they didn't have outward signs of liver disease like having a large spleen or low platelets or things like that. So that could be something where you have a subset of people who don't yet have liver symptoms, yet their readings on these elastography scans show that they may be at higher risk of developing clinically significant liver disease.
I think from the kidney standpoint, we could also use some of these MRF biomarkers to enrich. We are, thanks to COVID, got a little bit slow on our recruitment for our study, but we are looking longitudinally at GFR change and mean T2. So I suspect we will find that a mean T1 or T2 will be a predictor for progression. How much and how it fits into everything, but certainly as an enrichment tool, I think following along the same concept of what might have been used, of what was used in using the data in CRISP, et cetera, I suspect we could have some sort of imaging enrichment biomarker.
So I've advanced to this slide, and so we can use biomarkers in two different ways. We can use them as enrichment biomarkers, or we could use them as surrogate endpoints. And a question for the regulators that was brought up by one of the other, I think, on the chat and by one of our speakers earlier. What is the qualification process? How I mean, it took a long time to qualify total kidney volume, but I think that was because we were early in the history of qualification of biomarkers, but would certainly be interested in regulatory perspective on how these might be brought to use in clinical trials.
Yeah, hi, this is Joe. If you read through the letters of intent that are available in the public domain, you'll see that most, if not all of them, are starting with qualification as an enrichment strategy. So to select for patient enrollment into trials, that's really the first and quite frankly the most straightforward and perhaps easiest to qualify. But it stands to reason that once that's qualified as an enrichment strategy, that the next step would be, can this biomarker be used as an efficacy endpoint, either for a surrogate that's reasonably likely to predict clinical benefit for accelerated approval, or, as I was suggesting earlier, to push the envelope, and can that biomarker be used to ascertain clinical benefit as the clinical outcome to be evaluated. So the first step is an enrichment strategy, but again, stands to reason that there's more qualification work to be done in that setting.
I've listed the potential biomarkers that were identified in, these are imaging biomarkers. I believe some other blood and urine biomarkers were suggested in the talks. If there's any other comments about biomarkers, we have 6 minutes left. I'd like to jump to drug repurposing, which I think is back one slide. So Lisa reminded us that inhibition of the vasopressin receptor was shown in a rat model of ARPKD, even though it looks like ADPKD. And Dave has worked with tessivatinib in a phase 1 study in ARPKD. I don't know if you want to talk about that, Dave, or we could talk about these other newer agents which are being studied in ADPKD.
I could just bring the group up to speed. We did develop an oral formulation, a liquid formulation of tessivatinib, a tyrosine kinase inhibitor, that could be dosed by weight in a pediatric population. And because of all the challenges we've been discussing for the last hour or so, it's difficult for us to move that forward in the clinic right now. What we did is we did some preliminary phase 1 single dose toxicology study, safety study in ARPKD population, and we were able to demonstrate with a single dose that we were safe and didn't have a lot of adverse events. But I think that's where we are now. We're in a position of being ready to move forward if a suitable trial design that would demonstrate a treatment effect and still be able to assess risk in a risk-benefit way would be developed. That product is ready to move forward. So that's the update on tessivatinib.
Thank you. That's very encouraging.
So Ron, I just wanted to use this slide to make a point. Most of the drugs on this slide address epithelial pathobiology. The bardoxolone agent is important because, as is true for ADPKD, it may even be more true for ARPKD, that inflammation and fibrosis are really a critical part of disease progression. And so when we're thinking about drugs, and particularly repurposing drugs, we have to think about PKD in general, and I would dare propose, maybe even more so for ARPKD, that we be thinking about the non-epithelial compartments, inflammation and fibrosis.
Thank you. So we have 4 minutes left. So the last slide I was given to wrap this up. And I just want to say, I think this has been an extraordinary discussion. We clearly should get together and publish it along with the other sections of this meeting. One of the questions on the chat, which I thought was very interesting, from Chris Brasconi. Do you think an externally led patient-focused drug development meeting represents a good option to help understand appropriate trial design for ARPKD? I know the agency has had such meetings, and I think that this might be a reasonable thing to think about once it's possible for all of us to safely travel, or, you know, again, we could even do it by Zoom. And I think also, you know, for those who aren't regularly involved with the PKD Outcomes Consortium, we have monthly teleconferences attended by a large group of folks such as yourself, academicians, folks from industry, regulators, and patients. And I believe that we've elevated ARPKD clinical trial discussion to I haven't discussed this with John Michael or anyone else, but I think it's sort of obvious on its face that this is an important area that we need to keep talking about, because I've certainly learned a lot, and I think there's been a lot of tremendous insights that have been shared. So we're 2 minutes early. Final comments, panel?
So Ron, you welcomed folks. Please, Kertita.
Just wanted to say that, you know, I think a patient-focused drug development would be an excellent idea for this disease. It's certainly been, you know, very, very helpful, informative for other diseases also, so strongly encourage that.
So Ron, I just want to add my thanks to the panel and to terrific talks from Aram and from Max. I think that this just feels so hopeful. Picking up on Julie's point about lack of knowledge, but even more devastating is the lack of hope. And I think that what this session this morning has really injected a view of there are things that we know that we can build on, that we can move forward, and thinking about how we understand the disease, and that as the sort of the moving us along the road towards targeted therapies. So I really want to thank the speakers and thank the panelists and thank the folks in terms of the great questions, and we didn't get to all of them, that were posed in the Q&A and in the chat. And I do love your idea of putting together a thought essay. I know that the Europeans have thought about this for ARPKD. And I think that, you know, this is really a global effort, because it's true in pediatrics that rare diseases require, you know, multi-site studies. And because we are so connected to one another in PKD, I think this would be a very important contribution to help guide us forward. So I do want to thank the folks for this morning's session. I really thoroughly enjoyed it.
I'll also extend my thanks to all the panelists, all the questioners, the speakers, to Julie for sharing her story. And just a little bit of housekeeping. We have, I believe, a 20-minute break. Wendy's going to put up the instructions. We'll be back at 12:10. And we will answer all the questions. Lisa and I will be busy in the future, but we do promise to answer all the questions, and this discussion has been recorded. So thank you very much. See you in 20 minutes.
Thank you.
Hello, everyone. Welcome back to session 2. Just for folks that weren't on session 1, my name is Wendy Vanasco, and I am a project manager for the Polycystic Kidney Disease Outcomes Consortium at the Critical Path Institute. We want to welcome you all here and welcome back if this is your the second session joining us. Have some really quick housekeeping items to take care of. So I'm going to show those really quickly. Just so you know, all participants, your lines are muted. So if you need to connect with anyone during the call, please use the chat feature at the bottom right of your screen. Second, when we get to the panel discussions, if you could please submit your questions, if you have any questions at all, through the Q&A function. And you can find that by clicking those little ellipses next to the chat button at the lower right of your screen. So please send your questions to the Q&A. We'll be looking for them there. And hopefully we'll get to answer everyone who has a question. Also, third, just to note that this meeting is being recorded. So, and it will be available on the CPATH website after the event. So you will be able to go back and watch the recording as well. One final note, if you need any help at all, any assistance, please feel free to contact my colleague, Kitty Boji, or myself, Wendy Vanasco. Our emails are listed here, and we'll try to expeditiously help and answer any questions that you have if you have any issues at all. So, and with that, Chris, I'm going to go ahead and turn this over to you.
Wonderful. Thanks, Wendy. Hey, welcome everybody. If you joined us for the first session, we're very glad to have you back for the second one. And if this is your first session of the day, welcome as well. This session is on advancing drug development therapies for Adpkd. I'm Chris Rusconi. I'm the Chief Research Officer at the Foundation, PKD Foundation, and I'll be co-moderating this session with Arlene Chapman. If we could go to the next slide. Wendy, thank you. Hey, so this is what we're going to be doing this afternoon. I'll give a brief introduction, really highlight some of the pre-recorded material and tee up the panel discussion. Turn it over to Hayley Wormack, who will share her perspective as a patient with PKD, and then we'll spend the lion's share of our time together this afternoon with a really excellent panel addressing what we hope are some topics that you'll find very interesting in thinking about the next steps in therapeutic development for Adpkd. If we go to the next slide. So again, hopefully you've all had a chance to see these. We have 3 great pre-recorded talks from clinician scientists and 2 from patients. And if we flip to the next slide, just really want to thank everybody, all the speakers for the effort you took. If you haven't had the opportunity to watch these, please do. They're really fabulous, and you can see the thoughtfulness that went into these presentations. I particularly like to thank our patient speakers, Lainey and Karen, as well as our clinical science speakers who have given us 3, I think, really lovely and important presentations. And so what I'll do for the rest of this intro is highlight, as Ron did, a few slides from each speaker, and then talk about some other topics that we want to hit on the panel. So if we could go to the next slide. Thanks, Wendy. So Nir provided a really wonderful, I'd say, soup to nuts talk on Adpkd, ranging from disease presentation to our current best views on risk stratification and patient care. And I thought this was a slide that I wanted to highlight on a few key points. I think we've probably seen this in a variety of forms, but it highlights that, as we all know, that Adpkd is a progressive disease, and that over time, as the kidneys grow in size, it leads to continued damage to the kidney. I think importantly, that's characterized, as Nir pointed out, by loss of renal vasculature, pruning, and ischemia. And I think importantly, when we're thinking about some of the things we'll be talking about today, that kidney function changes over the course of the disease, even as the damage is occurring, ranging from normal kidney function to periods of hyperfiltration, leading to impairment, in many cases failure. And so I think as we'll talk about thinking about drug development, this impacts how to think about therapeutic development for this disease. And obviously, those aren't the only symptoms that patients are experiencing. There's other important symptoms, including hypertension, pain, and proteinuria. So if we flip to the next slide, the second bit that I wanted to highlight from Nir's talk is that Adpkd is a systemic disease, and with multiple extrarenal manifestations. And I think, as Nir pointed out, from a clinical perspective, the ones that are most concerning are intracranial aneurysms, liver cysts and comorbidities, and the cardiovascular complications. And again, we'll spend part of our time together today talking about drug development for manifestations outside the kidney with a focus on the liver. If we flip to the next slide, I think, Jalila gave a really important talk that reminded us all that the AD and ADPKD doesn't stand for adult. And I think really highlighting that ADPKD is a lifelong disease. It greatly impacts patients in childhood. And I think she made a really strong case for early intervention in childhood for some patients. And I think she highlighted on this slide, a reasonable percent, 2 to 5% of patients present with a broad phenotype in ADPKD as children. And she highlighted that there's some similarities with the adult disease, particularly in terms of impacts on urinary concentrating ability, on UTIs, and hematuria. And I think pointed out importantly also that there are a couple symptoms in particular that are highly prevalent and impactful in childhood, that being hypertension as well as proteinuria. And we'll certainly talk about some of these things, I think, as we get to the panel discussion. Now, one of the things that I think, if we flip to the next slide, that it was very kind of Jalila to share is some of the important work that her group's been doing, along with their work on the registry, and starting to develop risk classifications for pediatric ADPKD. And she presented the Leuven scale here based on 3D ultrasound. So it gives us, I think, a first step into thinking about risk stratification in the pediatric population. That's a really important tool. But at the same time, if we flip to the next slide, Jalila made a really additional important point that a lot of the tools that we need for development of therapies in children are lacking, in particular outcome measures and predictors of disease, and that a lot of the things that we've grown accustomed to using in adult disease are really hurdles in ADPKD research. And so certainly one of the things in the panel as we talk about the unmet medical need in children and developing therapeutics for children, we'll hit on hopefully a lot of these topics and talk about what the gaps are in these tools and what might be done to fill them. So if we flip to the next slide, Wendy, Roser's presentation was I think really truly masterful on the current state of the art in assessing rapid progression in ADPKD. And everyone, it's great that that's going to be a resource that will be up hopefully in perpetuity, because it's a really nicely structured talk. Walked us through the assessment algorithms with a deep dive into imaging predictors, laboratory predictors, and genetic predictors. And I think we could all appreciate the really nice balance she provided in the strengths of the research as well as some of the weaknesses of the tools that currently exist. And I think importantly, and I'm sure we'll have some discussion about this in the panel session, highlighted some of the potential new early predictors that are earlier in development, not yet qualified, that could be the focus of future regulatory interactions, in particular, textural analysis as an imaging biomarker, and then a number of potentially useful fluid phase biomarkers, including urine to plasma urea ratios, the chemokine MCP in urine, and I think a lot of interesting work going on in urine microRNAs to name a few. Now, if we flip to the next slide, this is starting to be a little bit of pivot to the panel discussion, but I think another point that Roser made very nicely is the utility of prediction tools to categorize patients for treatment, and highlighted what I think we all believe, given the progressive nature of this disease, is that the earlier intervention will lead to better outcomes. And she used this extrapolation from Fuad Shabib in the group in Mayo, I think, to make that point, which is essentially, if you look at the x-axis, say on the tempo data, intervening at a stage where patients have greater kidney function, is expected to lead to a greater preservation of kidney function over time and prevention of reaching end-stage renal disease. And so I think it highlights part of what we'll want to talk about today is how do we start moving the treatable population to that earlier in disease from a drug labeling perspective, and what are the tools and what are the things we need in order to do that. So if we flip to the next slide, this is both, again, a transition to the panel. And this is really both a thank you and a call to action, because it's from the work of many of you who are here today participating in panels, participating as speakers and in the audience, that we have a really solid pipeline for ADPKD, and that's really fantastic. And now the call to action is, at this stage, based upon, I think, pragmatic considerations and the regulatory precedent around tolvaptan, this pipeline is still largely directed at treating the adult ADPKD population at rapid risk of progression. And so, as I've said a few times, what we'll do in this panel session is talk about the need for two things: earlier treatment, as well as treatment of manifestations of the disease beyond the kidney, which aren't largely addressed in the current pipeline. So just a couple more slides before we move on to Hayley. So if we flip to the next one. So I really like this image because I think it's rich in information highlighting the spectrum of the disease, both the timing and the onset of progression. And so if we, one click, Wendy. So in the red boxes here, highlights really who are the current patient population treated per label of approved therapy. And it's really, the adult population bracketing around 40 years of age who are at rapid risk progression, and then younger adults with severe disease progression. And if we think about the current unmet need, it's highlighted in the blue boxes is, okay, thanks, Wendy, is, there are other probably populations, both in children as well as adults, who would really benefit from treatment. And so part of the challenge in thinking about the next phase of drug development is how do we expand the treatable population to those folks shown in the blue box. And so we'll spend some time on this. And then just on the last slide, the second focus of what we'll address in this panel session, if you could flip slides, Wendy, thanks, is let's talk how we approach developing treatments for extrarenal manifestations. And given its prominence and large impact on patient quality of life, we'll largely focus that discussion around liver cysts and liver cystic disease and Adpkd. I think Neera did a great job highlighting this in her talk, but a few of the points that I think were important to share is, liver cysts have a tremendous impact on patient quality of life, and that the treatments currently used to manage liver cystic disease are surgical or off-label therapeutics, and they really depend on what the cysts look like. And I think the other important point that Neera made that may come into the discussion as we talk about the potential for labeling drugs for treatment of this aspect of the disease is that the complications that patients experience really relate to the cyst and the size of the cysts. And so, as I said, we'll spend some time on this topic as well as part of our panel session. And so with that, what I'd like to do is, if we flip to the next slide, is introduce Hayley Wormack. So you can read Hayley's bio here, but she's currently a medical student in Kansas City. She's diagnosed with Adpkd at an early age and has been a really great volunteer for the foundation, and just really grateful that she's joined us today to share her perspective and participate in our panel. And I think, as we've worked with her, just really greatly appreciate the thoughtfulness with which she's brought to this presentation. So I'll turn it over to you, Hayley.
Hello, thank you, Chris. So like you said, my name's Hayley Wormack. I've been working with the PKD Foundation for the past 4 years, and I've been going to their walks for a lot longer than that, since around the age of 8 when I was diagnosed. So to get started today, I really want to thank all the panelists and the attendees for taking the time to be here and for all the hard work that's been put in trying to treat my disease. It really brings me a lot of hope and comfort knowing that so many great minds are at work trying to solve this problem. So I think after watching the videos for this session, it became really clear to me that there's an overwhelming need to establish new biomarkers to identify the rapidly progressing patients, and maybe even the ones that are more at an intermediate risk.
And that in some ways I should just worry about it.
Can you hear me, Chris?
Okay, I'm sorry. There, my bad.
Yeah, I'm hearing you now again, Hayley.
Okay, sorry about that. They just died. Anyway, what I was saying was, after I was watching the videos for this session and all the research behind what's going on right now, it really became more clear to me that there's an overwhelming need to establish new biomarkers to identify the rapidly progressing patients. And, before watching all this new research, I felt pretty helpless as a patient. I kind of felt like this was a leave it for later type of issue. And, that it just was going to be something that I had to deal with when my kidneys started to fail. And I think after seeing all the stuff that's being done, I don't feel like it should be seen that way anymore. I don't think it's a leave it for later type of problem that I used to view it as. And I think a lot of patients still view it as well as some physicians. So in efforts to better understand the role in my role in this session, I read over some of the FDA's guidelines for clinical trials just to get a better understanding. And something that really stuck out to me was the consistent mention that the function of drugs and subsequent clinical trials should all be surrounded by something that matters to the patient. So that was the phrase, something that matters to the patient. So with that in mind, here are some of the things that matter to me as a patient. Obviously, outcomes are my primary concern. And I think for me, the most desirable outcome that applies to every population discussed in the PKD community is that any treatment is welcomed that results in early prevention. And by early prevention, I mean interventions that occur before significant kidney damage is done, whether this is through increased or measured through increased TKV or a dropped GFR. And I have to say, like, I'm very happy to see that we're kind of shifting away from GFR being the primary marker for kidney function, because I think we all know that, you know, by the time you see that drop in GFR, a lot of kidney tissue has already been lost. And as a patient who still has perfect kidney function, and the only focusing on my GFR kind of feels like an injustice to the damage that is still occurring within my body right now. You know, despite my kidney function and my normal outward appearance, I'm still suffering from this disease. I have hypertension, I get chronic kidney infections, and there's also the entire emotional impact of living with this sort of impending doom that I really feel like I can't do anything about. So I think there's a desperate need, again, like I said, for those that early prevention, and I have a lot of hope for newly developed biomarkers that were discussed, and I can't wait for them to be standardized and accepted. And I just think that there should be an overarching goal to expand the treatment population to include healthier younger adults and children, rather than remaining on this continued focus of treating only patients, or treating patients when their kidneys are already failing. You know, as it has been said, the earlier you can intervene, you know, the more kidney you can save. And I really do think this falls in line with a current shift happening in medicine, where prevention is becoming the primary focus rather than trying to fix a pathological issue in efforts to return it to a normal baseline function. The next thing I kind of wanted to talk about was, I think that if we are going to expand the patient population to a younger age, these drugs need to have extremely high tolerability, because most likely it's going to be a medication that one uses for the rest of their life. And I can say from my own experience, I watched my mom's, she's currently on the approved treatment for PKD, and the burden of side effects has been substantial. And it's definitely kind of steered me away from starting it at a younger age. I think this in part is due to the fact that I'm not really sure how much benefit I will get from the drug. And by benefit, I mean, I don't know for sure how many years of kidney function I will get if I do take the drug and choose to tolerate the side effects. And so I guess what it comes down to for me is weighing, you know, the pros and cons. If I take a drug with substantial side effects that may interrupt my day-to-day life for several years, then I want it to be worth it. And I want there to be the substantial benefits. And then, so another meaningful outcome for therapies is just anything that can really delay the onset of renal failure. And this might more so apply to patients that are in the earlier stages of chronic renal failure. But I think that this could be a drug that maybe is more tolerated, and it doesn't show an insane amount of slowing progression or decreasing TKV or slowing that, but it does give you a few more years of kidney function. Any amount of kidney function is significant, and I don't want to contradict what I said about, you know, with the drug that doesn't have, or has a lot of side effects and you still get 1 to 2 years. Like, that is significant to other people, I'm sure, but to me, I think it's the 1 to 2 years of kidney function without the significant side effects. And then finally, I think there's going to be, or there needs to be a greater focus on expanding the patient population as it relates to pain. I know pain can be variable across patients, and in my opinion, I just think it's such a significant burden placed on patients who do experience it. And to my knowledge, pain hasn't really been a significant player in the studies done on PKD in terms of biomarkers or as it relates to disease progression. And I do understand that it's a subjective experience and it's hard to standardize, but I would like to say, you know, if there was a drug that was developed for PKD patients and it didn't follow to those endpoints of, you know, just showing significant progression or a slowing of progression, but it did serve to alleviate that pain, I think that would be a meaningful enough outcome for patients to take it. Because honestly, the patients that I know who have pain, I mean, they're essentially bedridden for days, and it's a really awful thing to see. And it just completely disrupts what little time they do have left of the kidney function remaining for them. So I think those are like my main talking points. Again, I just really appreciate everyone taking the time to be here today. And I really look forward to all of the science that I've been seeing. It's really encouraging, and I can't wait to see what comes next.
Thank you. Hey, thank you so much, Hayley. I really appreciate it. I think we all really appreciate you sharing that perspective. And I'm hoping actually that we'll have a panel where we talk a lot about what you outlined as important outcomes for you and others like yourself. And I don't know, Arlene, if you had any comments or questions for Hayley before we transition to the panel.
No, I thought that was a terrific testimonial and a call to action. You know, I think young individuals who have been diagnosed with polycystic kidney disease have limited numbers of options right now. And so I think it's really important that we hear this and that we respond to it. So thank you. I thought that was fantastic.
Excellent. So yeah, let's start transitioning into the panel. So if we flip to this slide, I think we just start so that folks can identify voices with names. We'll just run down a list of participants and introduce ourselves. So I've already done that. Hi, I'm Chris from the PKD Foundation. Arlene.
Hi, I'm Arlene Chapman. I'm at the University of Chicago, nephrologist who.
Oops.
Lost some audio. Neera?
Hi, I'm Neera Dahl, and I'm a clinical nephrologist at the Yale School of Medicine. And I run our clinical trials program in nephrology with a heavy emphasis in PKD and see most of our PKD patients.
And is Ollie on?
I think Ollie's having a few technical issues. We're trying to get him signed in, so he'll be on very shortly.
Good. Well, yeah, no, it'd be excellent. Praveen.
Hi, everyone. My name is Praveen Jadhav. I'm a development team lead within nephrology at Otsuka. I look after the GnRQ12 program.
Romaldus.
Hello, everyone. I'm Romaldus, specialized from Europe. I'm a nephrologist, practicing not too much because I'm involved heavily in the clinical pharmacology, in nephrology, in the regulatory pharmacology. So I'm in MA involved in almost all renal-related procedures, qualification, blah, blah.
Wonderful. Jalila.
Hi, I'm Jalila Mekali. I am a pediatric nephrology from the University Hospital Leuven in Belgium.
Wonderful. Craig.
Hi, I'm Craig Ostroff. I'm a pharmacist by training. I'm the head of regulatory affairs for Goldfinch Bio, which is a company developing medicines exclusively for kidney diseases. I've been in regulatory for about 25 years now. About 10 years in cardiorenal, working at times in both the industry on tolvaptan, credence, and canvas programs, as well as some earlier roles when I served at FDA directly.
Wonderful. And I just realized that I totally skipped over Dr. Mystery Socratida. Sorry about that.
No problem. Hello, it's Kirtida. I am a pediatric nephrologist in the Division of Cardiology and Nephrology at FDA.
Great. And Dr. Stockbridge.
Yeah, I'm Norman Stockbridge. I'm the director of the Division of Cardiology and Nephrology at FDA.
Great. Dr. Turner.
Hi, I'm Joe Turner. I'm the director of the Division of Hepatology and Nutrition at FDA.
Wonderful. And Roser.
Hello, I'm an adult nephrologist from Barcelona, and I devoted my whole professional life to genetic kidney diseases, Adpkd among them.
Cool. And then we obviously all got to hear from Hayley, but just once again, hey, Hayley. Well, excellent. So we are, I think I'm really looking forward to this panel session. We have a great mix of clinical scientists, regulators, representatives from pharma industry, and as well as Hayley. And so Arlene and I will be co-moderating this. And as I said in the introductory remarks, you know, and I think really echoes what Hayley shared with us, is we're really looking to think about how do we advance drug development for ADPKD beyond the current treated populations. And we've lumped this into two broad categories. The first one being expanding the treatable population beyond adults at rapid risk for progression, and really trying to look at what are the currently untreated patient populations where there's an unmet need, where treatments would be impactful. And, you know, thinking about the future view of the consortium, what development tools are needed to expand those treatments to those populations. And just for clarity, we're going to largely focus on thinking about this in the context of disease-modifying therapies, those directed towards preventing cyst formation or growth, as opposed for treatments of symptoms, for example, like control of hypertension. And then secondarily, we're going to move beyond the kidneys and talk about treatments for extrarenal manifestations, particularly in the liver, and also talk, I think, you know, time permitting, talk also generally about, you know, outcomes broadly. And so with that, Arlene, do you have any comments before we hop into the first slide?
No, I hope we get a chance to really get some detailed responses from the different regulators about expanding eligible patients for testing new therapies, because I think all of the presentations highlighted this aspect, and so did Hayley. I appreciate making sure that patients that are known to have progressive disease are selected for appropriate therapies, but I think we all understand that ADPKD might be a little bit like global warming, right? Where it goes on and on and on, and no one's feeling too badly yet. And then all of a sudden that critical temperature is hit and there's no turning back. And I think I sense, and, you know, I hope that we're not missing opportunities to take care of patients decades earlier in the course of their disease. I mean, I think there are treatments being tested right now, but again, they're being tested in a very specific subset of individuals that exclude a number of patients who know they have ADPKD, know they have actually fairly significant disease severity, yet they can't be part of many of these new therapies that are being tested, and also may not yet fit what's criteria for treatment when they really will, but it's going to take a few years for them to meet that criteria. So I think is where the field of ADPKD is right now. I think we can safely say we've done a number of good things, and there are people now getting disease-modifying treatment. But I think we're really missing a large number of people early on in the course of their disease where therapeutic intervention actually has the biggest impact. So I put that out as an opening and hope maybe all of the moderators, all the panelists that would like to comment on that if they could.
Thanks so much, Arlene. Yeah, so and I think just to structure this conversation, what we've done is broken it down sort of from patients that are probably most closely similar to the ones that are currently being treated, and then moving down to the pediatric population before we'll pivot to the liver and general outcomes. And so I guess just to start, we've defined this as adults high risk of progression with normal kidney function. And so, you know, if one of the clinicians maybe Neera or Arlene could describe, you know, what does this patient population look like to set up the unmet medical need discussion?
Neera, you want to take that on?
Sure, I'd be happy to. So, Chris, I agree with you. I think right now a lot of the clinical trials are focused on looking at those people who are at high risk of progression. So primarily younger patients up to about the mid-50s who have large kidneys by Mayo Imaging classification. And what's a little perplexing to me about some of the studies is that even though they're using that as the entry criteria, they're also using GFR. And so they are looking for a loss of GFR, usually a GFR less than 90, to be entered into those studies in patients that we've already said, no, these are the rapid progressors. So I think there's still a little bit of a disconnect between using this very good biomarker on one hand as a selection tool, but then saying, oh, but by the way, we're also going to use GFR as a biomarker. But I think those patients are at least getting multiple opportunities to be in studies. I think the patients, so you mentioned the patients to the left of that, those at risk, but not yet maybe fully identified as being at risk. And I also sort of wonder, maybe because it's the patients I see, the patients to the right of that who will develop significant loss of renal function in their 60s and 70s. Right now, we have really no therapies targeted for those patients. And they're still, you know, ultimately they're progressing maybe a decade later or 2 decades later, but they are progressing. And perhaps there's therapy for those 1C, 1B patients that we're not capturing because of the way we're doing the trials. The other thing, so Hayley mentioned this really beautifully, and as I was thinking about this, I think pain is really a big unmet need. I think that's a very, very reasonable area to start thinking about and at least trying to capture in some of the clinical trials. And then finally, I think as we're looking at newer therapies coming online, most of the treatments going on right now are either the drug in question versus placebo. And there are patients who are now on tolvaptan therapy. So should it be on whatever your standard of care for PKD is versus placebo, right? Meaning that some patients in that placebo arm are going to be on tolvaptan therapy. And I think that really has to be considered as we move forward.
Yeah, and that last comment you made, Neera, is something that I know is going to be discussed really robustly tomorrow. So maybe you just dropped a please come back tomorrow for people, because I think that trial design question of standard of care and inclusion of patients on currently labeled therapy is going to be a pretty hot topic in session 3B tomorrow. And Arlene, do you have any additional thoughts to share? I mean, I think, Neera, what I hear you saying is this population, so rapid risk progression, or even, and we'll get on the next slide, not so rapid risk progression and normal kidney function. It sounds to me like, from your perspective as a treating physician, that you think this is a population that merits attention from a therapeutic perspective.
Yes.
Yeah, and I think, there's a lot of very good data coming out from the Mayo Clinic showing that some of the less severely affected individuals based on total kidney volume actually later on in life do have progressive renal insufficiency. They tend to be somewhat overlooked. The mechanisms for their disease progression may be quite different than young individuals with normal kidney function and large kidneys, but I think there's still value added for therapies that can delay their progression to requiring either dialysis or a kidney transplant, even if it is in individuals who are over 50 or 60 years of age, because mortality rates still change dramatically once renal failure has been reached. And I think we did a good job at picking out the people that are at definite high risk for progression to renal failure, but I think there are disease-modifying therapies that could be tested in individuals with somewhat milder disease.
And Rosa, as a treating physician, do you have anything to add to those points?
Yeah, I think there's a very important thing is the wording, the rapid progression. So it has been proved to be helpful to identify these patients, but what is exactly rapid? It means more than the mean age for that certain group, then we will only consider those who reach end-stage kidney disease before 58, around 58, which is the mean age for end-stage kidney disease. But don't we think that it is a very young age still nowadays? Or should we increase that? But then if we increase that, what's the meaning of rapid if some of them do better than the mean? So I think this is an important question, and perhaps it should be rephrased or whatever.
And if you had to rephrase it, how would you rephrase it, do you think?
I don't know. Yeah, risk of progression till a certain age. I don't know. It's hard to say which age, because depending on the population and each person, ages do not correlate. Biological age do not correlate with chronological age.
Something for us to definitely noodle on, because I think, Arlene, your description of global warming seems very apt and seems very consistent too with what Roser just said. I think that's a really good analogy. So it sounds to me like, at least from the clinical perspective, we would agree that this is an unmet medical need, which then sort of moves us down to the middle categories, because if you have to design clinical trials around the patient population, right, and think about expanding, then it comes down to, can we define this population? Do our existing tools that we've seen so much of in the pre-recorded talks, do they define this population? If not, what are the gaps? And do the biomarkers that we're looking at really enable characterization of treatment progression? Again, if not, what are the gaps? And so maybe, Roser, given what you were speaking to in your material, this seems like this is a good starting point for you. And then maybe we go hear from some of the industry folks as well.
Sure. In fact, perhaps I make some mistakes, because I use the term rapid progressors for both clinical trials and prescribing disease-modifying therapy. So it is different, because for clinical trials, you really want very rapid progressors, because it is the way to see something in a short period of time. From the clinical point of view, we would like to treat more patients. I mean, that they reach end-stage kidney disease older than 60 maybe, and treat patients without any GFR decline, so above 90, which is above the threshold for clinical trials. But I understand that, because, and I would love to hear the people from FDA, what do they say? But I remember from the TEMPO trial and so on that GFR decline was very important then. And this is why I think most of the companies choose GFR decline, because of that experience. We would love to use another thing as clinicians, because we believe it's somehow.
Yeah. Do we want to start dipping our toe into the kidney function question now? Because I think it's the heart of a lot of this. I don't know, Arlene, where's your head at on that?
I mean, I think this is where we just, kidney function and ADPKD are such a disconnect for 30 to 40 years. And there's true disease progression without any change in kidney function. As everyone was talking, I thought, what would make me satisfied that I'd done everything I could possibly do that I would prevent someone from going on to renal failure? And if I could move someone into a 1A category and keep them there, I would be satisfied. And it wouldn't matter how old they were. And I think that's a little different way of thinking about therapies, because we've used therapies that slow things. We haven't gotten a therapy yet that stops things. But, you could see if someone were considered, at risk for progression, and they went on a very effective therapy, and they moved their risk classification down to the lowest risk classification, then I know that I've done almost the best I could possibly do outside of ADPKD itself to stop someone from going on to renal failure. So we haven't used that. We've been somewhat, locked in, if you will, based on the approval requirements for therapy. And I think one could argue, even if you have a 1B person, if you could get them to 1A, there's benefit there. that people stay in their class throughout their life. They don't really change too much. And it's interesting, even once patients have reached ESRD, when you look at their kidneys, even for the next 5 years, they don't change classes because they had such extensive kidney growth before they got there. So I wonder if that's one sort of new step ahead for thinking about what is meaningful. And it's relying still on cyst burden. And the only reason I'm avoiding kidney function is I can tell you on the clinical side of things, when physicians see the impact on kidney function on an approved drug and see that in quantitative terms, it's significant. I know it's important. It's a mil per minute per year important, but that's often looked at as not a large impact on kidney function, right? And again, it's not because the drug doesn't have a big impact, but that's because that's the rate at which kidney function declines in the natural history of ADPKD. So if we're going to have to be tied to kidney function, it's going to make it very difficult for pharmaceutical companies to make any assessment of people in their 20s, 30s, and probably their 40s.
So that's I think a really important point, and maybe and we're kind of merging, I think, this slide and the next slide, which I think is totally fine because I think it's a really valuable discussion to have. And I'm wondering, for our industry members, Ali or Praveen or Craig, given what's been said, and I think sort of what Arlene was just reflecting, which is, maybe a desire to move away from an endpoint that's been sort of what you've probably sort of staked a lot of your development decisions on. What do you think about this population, and what do you think about how you go about developing therapeutics for them? And either of the three of you, please jump in.
Yeah, it's Craig. I'd like to start that first, if that's okay. So Arlene, I fully agree with you, and I think there's a balance between what's needed for patients, and then what we can get, and what we can get approved in a reasonable amount of time. So I think that clinical outcomes are critical here, but I wanted to maybe take a moment. This might be a good time to kind of set the framework for where the industry and clinical patient need kind of fits. Obviously, as you know, as you've been working on this for many years, industry drug developers aren't solely focused on creating a product that can just generate a profit. Any development pathway must have to keep the patient safety as a North Star. And what I keep hearing today, which is consistent, is, okay, we have people who are rapidly progressing. Okay, so there's that risk benefit. But what if we wind it back to people who are intermediate or even pediatric? How do we measure, how do we do this risk benefit where we have to first do no harm? And then we have to create outcomes of feel, function, and survive, as FDA says continually, Dr. Turner, Dr. Stockbridge. But that's only the first part of it. We have to meet fundamentally the different approval requirements of the global health authorities.
Right.
And we have to have a clearly identifiable population that can see a benefit in a reasonable amount of time. So that is why we ended up, as you well know, with the high risk or the rapid risk versus a 10-year program. But then it gets even more nested in the sense of that we might be able to make, industry can make the patient happy and the prescriber happy with all of the research, but then the payers have to be made happy with being able to create highly differentiated therapies that say, well, we're different than product A and product B, and then here are the values that we can show, maybe less hospitalization time, less use of healthcare utilization. So I think that's kind of the nest. A lot of this is arbitrary considerations in order to be able to make everybody happy and move forward. But I think we need to talk about outcomes that are beyond just the renal ones.
Absolutely, and I definitely want to start pulling the regulators into this discussion. Before we get there, Praveen, did you have any comments or thoughts on this?
Yeah, thanks, Chris, and thank you for inviting me to this forum. I'll follow up from what Craig said here. And Arlene, I really like the analogy of global warming, because if I take that and say, we chose to act on the first probable cause, say TKV, and we said, oh, fossil fuel was a bad thing, so let's get ahead of that. But then there are these other things that come along that are not well understood. And I think the dilemma here, what Craig alluded to, from the developer or from the regulator perspective, how do I design a trial, or how do we design a label that we can actually show to the prescribers? But then from what I hear in this panel on from the treating physician side is, how do I treat my patient? Not the average patient that probably exists somewhere that we summarize our mean data. And I would like to point out, though, that we have come a long way. I have a benefit of sitting on this side of the aisle on industry side. But back in the days when we were debating TKV, I was on the FDA side. I mean, that's actually a much progress on making TKV as a reasonably likely surrogate and allowing therapy, because to Craig's point, that has reduced the trial duration, as well as has allowed us to do trials. But I think the next step is to add these other aspects that Hayley was talking about. How much does the pain count? How much does other symptoms count towards that risk for rapid progression? And I think this population, for example, comes in our conversation quite a bit. They have met the TKV criteria, but their kidney function is normal. And in our physician interviews, there is basically a wide variability on how physicians are thinking about it. But from, again, if I think about the drug we have, this population is approved, but at individual level, there is still debate. And I think there's a knowledge gap that we still need to fill. On the treating physician side, how do you judge that? It's really a patient by patient call.
Thank you. And so let's pull Dr. Stockbridge or Turner or Romaldis or Kurtita listening to this conversation. And I think some of what both the treating physicians as well as the industry folks are raising is, clearly there's a desire to treat these patients. And if we think about the next slide, a desire to treat patients who are maybe even more intermediate risk, but that focus on kidney outcomes or other things like that may prevent the development of drugs for this population. So how do you react to that? And how would you advise people to think about that?
So this is Norman Stockbridge. Maybe I'll start and others will give their perspectives too. I want to point out that every time somebody prescribes a drug, they are doing some form of generalization of the trial results. They interpret the trial results, the labeled indication, as applying to the person sitting in front of them. So the issue is really, where do you draw a line? And for the one drug approved in this condition, it's worth looking at what we did when we wrote a label here. The label refers to a high-risk population, but it doesn't characterize what those patients were in the indication statement. It doesn't limit it to people who looked particularly like the ones in either trial. And the two trials had pretty different inclusion criteria. One of them was based on TKV being at some level by some age. The other trial had GFR below some level by some age. But neither of those characteristics are part of the indication statement. So where you draw the line and where it might be reasonable to further test is not at all clear. And I think I think we might even have not said high-risk patients had the treatment effect of tolvaptan been substantially larger than it was. I think the main reason why there's a qualification there at all is that we thought that the evidence from the first trial was, the effect is pretty small. We need to make sure it actually, in some form, looks like it will persist with long-term treatment, or nobody will get any benefit in terms of delaying end-stage kidney disease. And so the second trial got done. But if somebody comes to the table with a larger treatment effect, there's pretty good chance neither we nor you will question whether or not earlier use might be appropriate. So those are my thoughts on this.
Thank you. And Romaldus, do you have anything to add to that before we maybe flip to the next slide?
Please. I raised it in my head when we talked about Gfr and uncertainty about. Sorry, I have echo. Reason for that. I think that first of all, we need to understand that we are not only in the global warming, but also plus COVID global warming. And to me, the main concern is always that creatinine is the only GFR representative marker, which we are happy for many years already. And in this particular PKD case, we have hyperfiltration, which is pushing all our efforts to measure GFR to nothing, the very big, similarly like in diabetes, like in many other areas. And I think that what we should start thinking, that we should be maybe working more on at the same level granularity of the GFR marker like we have in TB. We go now the texture, so many funny things which makes us happy, and I agree with the presenters in the recorded lectures, with the many other literature that this is really favorable and promising thing. But for GFR, I still believe, I really truly believe in GFR as a marker staying most in the CKD area, and here we are also in CKD area, but we need to do more basic science behind that as having new biomarkers in that area. And I think that this is something that we should consider. The first comment. Second comment about this high risk and the rapid progression, etc. I think that we also need to understand that we need sort of consensus now, and I assume for some time in the future as well. Because you see, we have one algorithm in the US, we have another algorithm in Spain presented, and we need consensus. And I think that this forum is something which might help in that direction to agree, not the best, to something. And then regulators could step further, thinking about this high risk, rapid progressors, non-rapid progressors, etc. To me, rapid progressors, they are little, somewhat regulatory invented, also at least contributed by regulators. Think why? Because if you remember, we approved the tolvaptan, we could not go for the treatment of the PKD because there was not some data on GFR, not sufficient data on the heart endpoint. So in Europe, when we go to the slow progression, slow enlargement, which was true, and you can never contradict that. So how far it is important, I don't know. For the time being, yes, it's important. But at the end of the day, we need all disease, the very beginning to the end, to treat it. And now I come to my last point. I think that we not forget that we are dealing with the irreversible disease, genetically irreversible disease. If cysts emerge, it's increasing, you will not go back. Usually what the regulator makes also that maybe this is reversible, maybe to show long-term sustainability, and then we go to certain time frame, eat among nephrologists. No, I think that we should think more on the concept. This is irreversible. We need to stop as early as possible irreversible changes, and whatever helps us, whatever biomarkers, clinical and outcome measures, it should give us opportunity to go for label at one or another area, because we cannot speak or let's say work in the regular language of the mortality, doubling Gfr, etc. So I think that these are concerns from my side as a regulator, seeing that they are a little bit incapable to catch the visibility, and that's why we then go to quite rigid, quite sensitive markers, and none of us is.
Yeah, so thank you. I know that while we've been discussing this, there's been a number of questions that have been put into the chat and question and answer. I know there's one in particular from Anna that has gone to Rosa. Rosa, do you want to talk a little bit about the PKD2 mutation and EGFR, but significant cyst growth?
Well, I could just mention that as a cohort, genotype phenotype works very well because in large cohort, definitely PKD2 it's less severe than PKD1, and truncating PKD1 is worse than anything. But at the individual assessment, this is not that relevant. I think we should trust the imaging and of course GFR. So do not rely too much on genotype an individual level.
Yeah, nice. Thank you. And then there was also a question from Thierry Christophe about perhaps we would be better off with a composite endpoint for ADPKD clinical studies, so that way different aspects of the disease could be addressed in a therapeutic evaluation. Is that something the FDA could or would consider? And I can tell you historically in the TEMPO trial, it was a composite endpoint, so I think the answer to that would be yes. But I don't want to speak for the FDA on this one. So would someone be willing to take on that question?
Tita, do you want to answer that?
Yeah, we certainly would be open to composite endpoints. I think we have to kind of make sure that these endpoints are clinically meaningful. But yeah, we have looked at composite endpoints in other clinical trials and are open to doing so for future trials.
Great, thank you. I know Frank Zerwick has had his hand up now in the chat room for at least 10 minutes, so that he doesn't get digital ischemia. Frank, would you like to say something?
Oh, thank you for that. I've studied Raynaud's disease in the past, but no, I just wanted to extend some of Dr. Stockbridge's and some of Dr. Matsoulides' comments with regard to understanding. It's critically important, or at least I feel it's critically important, to be as transparent as possible and share as much data as possible with regard to the clinical studies. And the label does a very good job of summarizing that. But there are a number of publications that Otsuka has put forward, and the authors, the steering committee for that program, that address a number of these questions, including, what did the pro-PKD score look like? How does the Mayo classification work? And importantly, a summary of the information available with regard to toxicity, specifically liver toxicity. So I think it's important as we move forward, gather additional information in other studies with other drugs, or in post-marketing evaluation and safety evaluation of these drugs, that these things be published, made part of or integrated into clinical guidelines for physicians to use when they consider treatments for their patients. That's the only comment I wanted to make.
Great, thank you. There's also a question from Craig Ostroff to all of the panelists. Other plausible renal outcomes to consider to support patient benefit: time to a number of events such as dialysis, renal replacement therapy, decreases in hospitalizations, perhaps non-renal outcomes, including liver cystic disease, cardiovascular or neurological involvement, patient-reported outcomes, use of less pain medication, use of real-world data for benefits. Would even a MACE endpoint be plausible? And so I wonder if, Neera, do you want to tackle these questions? They're all very good. Is Neera still with us?
I am.
She might.
No, I'm sorry. I am, Arlene. I was actually, while you were talking, I was looking to see if I could see the questions. And so the question is,
it's in the chat function if you go to the right.
Okay.
Sorry, it's in the patient answer. Yeah.
Okay. So I guess the question here is, would some of these be used as outcomes? And I think that that's reasonable, except that some of the therapies are very, very specific towards cyst growth, so that it may not really be the appropriate, those other sort of broader composite endpoints may not be the appropriate target for something that's specifically looking at a renal specific indication. I don't think we know fully what's happening with polycystins and with that pathology in some of the other organs, in the vasculature, for example, or how it affects cardiac outcomes and things like that. And so I think that it could be broadened to some extent, right? Should it be brought into for pain, for example, or should it be broadened for other things that are cardiovascular outcomes? I think that's a reasonable question to think about, because we want to see that our drugs are also effective in that area. But I would be worried about a drug that's too broad in terms of the extrarenal manifestations.
Great, thanks. Rosa, do you have anything to add to that?
Well, I agree, and I think, well, as you mentioned in the TEMPO trial, there was a composite endpoint, and I think that it is a great idea, but when really using symptoms or signs that are attacked with the drug, by the drug. Yeah.
Excellent. I'm cognizant of the time and also very much enjoying this discussion, but I wonder if we could skip, maybe we skip 2 slides and we start talking about kids, and if we have time, we talk about tools, I think, because I don't want to miss out on our opportunity to talk about children, the liver, or a general outcomes conversation either. So I wonder, Jalila, if you could kick us off talking, maybe, talking about patient population, what you see as the treatable population in children, just to get this conversation rolling.
I would first start, as a pediatric nephrologist, I am really, really very proud and delighted to be part of this discussion, because a few years ago during my PhD was Adpkd considered really as an adult onset. And testing children or seeing children was actually really a matter of controversy. And it was indeed very difficult to discuss with our colleague between finding the balance of not medicalizing these asymptomatic children. However, we were also speaking on that we should not miss the treatable disease modifying symptoms at early stages. So I was really actually very pleased that Hayley, as a young adult who had her diagnosis as a child of 8 years, highlighted very nicely that actually the children are very early aware about their risk. And I loved her sentence saying, "I was watching my mom." And actually, that is what I am hearing in my Adpkd clinic, that all these children are hoping to do it better than their parents and much better than grandparents. So two things that Hayley mentioned, and I would like to discuss actually, is the importance. So she highlights the importance of tolerability. So if we start treatment in childhood or young adult, we should think about long-term use and tolerability. However, I think really that this decision needs to be discussed with the patient himself, and it is not a decision of the clinician. And I was really surprised because I participated in the tolvaptan trial where all the colleagues were saying that it was not applicable for children and we should not do it. And I was very surprised about the motivation of these adolescents and children on taking their tolvaptan. And even with drinking and peeing 6 liters, they were very motivated because they had the feeling that they are doing something in for their disease actually. So the second thing that Hayley also highlighted very well, and I think that is very important in clinical trial in pediatric, is in this population, it is more difficult for us to find endpoints as EGFR is much or less evident for this population and TKV is not yet validated. So my group is working on it to try to stratify these children with the very nice collaboration with the Mayo group, where I am very thankful because we learn from our adult colleague to move on in the pediatric research. But what I would like here to mention is that we can already play a role as a pediatrician to control the blood pressure, which is one of the main early symptoms in childhood and also one of the main comorbidities in adult population. So if we can maybe focus on hypertension on childhood and maybe use it in a clinical trial. And the second thing that Hayley also mentioned very nicely is that we cannot forget that there are, beside the TKV and the EGFR, that there are other patient-centered outcome measure like pain or even quality of life, feeling much better because we are doing something on our disease that might play a very important role in a clinical trial, and maybe it can be used as an endpoint.
That's great. I mean, I would have to tell you, even with my adults with ADPKD, they track their own course to their parents. You know, it's a phenomenal issue for everyone with this disorder, you know.
Yeah, but they are very early aware about it and they worry about it. So they are really, so I am really pleased and very happy that the research is getting more importance in this population.
Do you think there are any potential candidates that the regulatory agencies would allow for children with ADPKD, I mean, I realize that height TKV has to be validated in the
Mhm.
context of normal growth. Are there any other
Mhm.
variables that you think could be considered?
So I think, you know, we start always based on your finding on adult and young adults. And as you said, the ProPKD score was actually mentioning if you have hematuria or you have hypertension before the age of 35 years, you are in the category of at risk. So if we start already shifting the age of 35, saying before 18 years of age, maybe we already define a high risk group. If you have hypertension, urinary tract infection, hematuria before the age of 18 years, it can be also used maybe as a high risk. And we are now really working very hard on getting this TKV, because we see already children with very young age with already huge kidney and lot of number of cysts, the type 1 ADPKD, not only few cysts and big one. And actually we they can be also used with this.
And do you think that there could be a urinary marker at all? I know that proteinuria is more common in children than adults with PKD, which I thought was always quite interesting. And hyperfiltration seemed to be a problem as well.
Yeah, exactly. So what I'm thinking about the urinary biomarkers, I think personally that the young children and the young adults are the best candidates to study for biomarkers, because they have less CKD and less inflammation and less fibrosis. So we will maybe really find the initial cyst markers of the cyst formation markers. And that's why I am doing this biobank all years and working on it to find out. And our first finding, we saw already that urinary MCP1 is increased very early in childhood with really normal GFR, very few cysts, in a very nice characterized cohort. And we show already that there is, which has actually increased the thing that maybe inflammation is started also very early in this population. So I think really that is a more pure population to study early biomarkers, because you have less bias than an adult with a lot of drugs and a very severe phenotype.
So that's a really interesting point. I saw, Rosa, it looked like you had your hand raised. Is that true?
Yeah. I wanted to make a comment. I always tell Dalila the same thing, but it's quite surprising, as Lynn mentioned, that our young adults do much better than kids. So this is we assess the population with all the prediction tools. For example, the ProPKD was very specific, but with very low sensitivity, because in young adults, even having truncating PKD1 mutations or being 1D, 1E, they had no hypertension, they had no urinary tract infections or whatever. So apparently, yeah, I mean, if we think on, this is my opinion, on stratifying kids based on symptoms, on hypertension or urinary tract infection. I mean, urinary tract infection because of cyst, not because other usual things in kids. I'm afraid we will lose many of them, because this is what happens in young adults. Huge kidneys, and I mean in their 20s, not in their 30s or 40s, but in very young adults, huge kidneys and no hypertension, no infections.
I'm wondering, watching time a little bit, I'd be interested in, Craig or Praveen, when you think about drug development and some of what Jalila and Rosa have shared, how do you think about this population from a development perspective?
Yeah, I can go first. I mean, I think Jalila, in her talk, she talked about Leuven classification. I mean, that's to me is a progress towards what we need, because we have in adults Mayo classification. Now we'll have Leuven classification, and some of our internal data we already see what I would term, and we work with a lot of folks on the panel, I would term as large kidneys. And having some common understanding what is large, I think we're getting there, and I'm hoping eventually we'll have something like a hybrid Leuven Mayo, so it kind of continues, because it's a continuum of a disease that starts at a birth. I mean, that's sort of what's highlighted at the beginning. So as far as the risk for progression goes, unmet need, I think we are making good progress. And hopefully with these tools, and Norman also mentioned, from regulatory standpoint, it's a slightly separate question. But then also, I think we are getting a lot of data. So again, you have to compare 2-3 years ago. There are studies, at least 5 studies I'm aware of, including one of ours, that are either ongoing or completed in pediatric Adpkd. That itself would give us more data on how to think about the registration outcomes. And including, I think what was highlighted is learning from adults, because it's the same disease, it just has manifested early, and perhaps where we have limitation is the numbers. The number of patients who look like they should be treated in their as their counterparts in 50s and 60s are less, and that's where we can leverage a lot of combined data. I think Frank mentioned importance of data sharing in a different perspective, but here also I think we can collectively look at all the data we have generated so far and come to common understanding of defining risk for rapid progression, but it's also getting the product registered and calling it safe and effective, because at the end of the day, what we want to do is make sure that the safety efficacy is balanced. And I also want to thank Jalila for that comment on the importance of the patient's role in this, because we can develop drugs for average patient, average population, but at the end of the day, it's the conversation between that physician, that patient is really important.
Yeah, good points. So I agree with Praveen here. It's, my goals in pediatrics are, I always think about safety, 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 and whether I would use this in my own children. Is it ethical to do the study in children? And can we make, whatever we do, can we make it easier for the parents and children to be on the therapy? We don't want to, we don't want to cure the disease, but then make the parents and children miserable through the process. It's really that potential risk-benefit trade-off. And it was discussed earlier, you can't have outcomes if the product doesn't impact mechanistically that area. But we have to really identify, based on what the drug is, what that outcome could realistically be. Identify potentially, Chris, what that patient subset would look like. And see if we can consistently identify that. I'm sure that patients want to extend that runway of kidney decline that they're aware of. So we look for a disease-modifying approach potentially. I think about the late-stage patients that we researched on tolvaptan, how that disease is different, but the fibrotic disease. And I'm thinking if I had a family member who had PKD, Adpkd, I know that I would want to keep them out of that fibrotic stage as long as possible. Because today we don't have this, maybe in 5 years we'll have products that can treat that. Maybe that's the conversation we should have, during this meeting today. But we want to delay as soon as possible, but it's that risk benefit in finding the specific spot to intervene.
Thank you. I think it sounds like time to probably pull the regulators into this discussion. So Kirtida, as a pediatric nephrologist, listening to this discussion and thinking about what might be able to be measured in kids, can you reflect on how you think about drug development for this population?
Yeah, I think this is a really important issue. We have had challenges in the space, in a disease that is genetic, that starts at birth but progresses over time with age. One of the questions when it comes to pediatric patients, and Norman, Dr. Stockbridge brought this up, internally, is when is too early to treat? Can we identify this population early on in childhood that will progress? And it doesn't have to be rapid progression. It could be progression, a lifetime risk. But can we identify that population early in childhood, especially younger children? Older adolescents, probably there are criteria that could be used similar to adult risk stratification criteria, like the Mayo criteria. But in younger children, that's a challenge. And like others said, it's a risk-benefit issue, and that plays into it. In terms of, a condition like this that is rare, that affects adults and children, if we can identify this population early in terms of, as I said, this lifetime risk of progression who could benefit from therapy. One of the things, that we've done and that is being done, from a regulatory perspective in terms of endpoints and clinical trial design, in terms of feasibility, is leveraging the data from adult trials. So what endpoints, in adults, and what biomarkers, surrogate and, biomarkers or other biomarkers in adults predict treatment effects on clinical outcomes in adult patients with ADPKD. So we use what we call a bridging biomarker. So it's a little different from a surrogate endpoint, but leverages data from adult patients and adult clinical trials. So if we can show that, that biomarker predicts outcomes in adult patients, but also explains a fair proportion of the treatment effect. And if we know that that biomarker tracks with outcomes in pediatric patients based on, published literature and natural history studies, then we can leverage the data to partially extrapolate efficacy to pediatric patients using this bridging biomarker approach.
Thank you. That's I don't know if anybody else wants to comment on that, but what I'm hearing is, a lot of role potentially for the consortium and things going forward. There's obviously a large database of adult data. There's a lot of quantitative modeling going on. And I think about some of the registry work that Jalil is presenting. It does sound like maybe there's opportunities there to think about what are biomarkers that that could be bridged to bring back into the child, the young population, to think about a treatment effect, so to speak, or a progression biomarker, or prevention of progression type of biomarker. I think that's really that's a fascinating point, and I think one well made.
And just actually, Chris, to follow up on that bridging biomarker, a good thing is a template to work with the agency on that is available in many, many diseases. So agency is really open to that. And I think all of us should really leverage those precedences in terms of making up a case on unmet medical need, the predictive ability that Dr. Mistry is talking about. And areas like PAH, the pulmonary arterial hypertension has used that, an antiviral that has been used. So we really can work together to get those through the finish line.
Dr. Mistry, has there been a good example of a bridging biomarker in other kidney diseases being evaluated?
There's a lot of experience in the heart space. So, for example, if people are interested in looking this up, and this is public, is, for example, for Entresto for heart failure, use this approach, and that review and labeling is publicly available if people want to refer to that. In terms of how we approach this issue. And Dr. Stockbridge is an expert, and so he may have more to add on this too.
I don't actually have much to add. The settings in which we've done this successfully have been the cardiovascular ones. But that's a setting where the children have events. We bridge based on the biomarker, but the events we are hoping to prevent aren't 3, 4, 5 decades down the road. It'd be a stretch, I think, to bridge into a population where we can validate that the mechanism of the drug is preserved, but the utility of starting early is not so clear.
So in that setting, I mean, to jump in, it seems like the issue we've kind of danced around a little bit is, it's clear that the kidney is being damaged and the kidney tissue is dying, and that the current measures aren't really measuring the destruction of the kidney tissue until it gets to an advanced stage that manifests itself in their kind of classic kidney function outcomes. So and I do want to talk, we do need to get to talk about the liver here, but what about things like renal reserve, or those of you who are really focused on biomarkers, measurements in the kidney that reflect the tissue damage long before we see functional changes in things? Because it sounds like, I mean, in part in kids, that's obviously happening. We just don't know how to measure it right now. So I don't know if Roser or Jalila or anybody who likes to make tools to measure stuff would like to comment on that.
Could you repeat, Chris?
Yeah, it's the question is I think Dr. Stockbridge just laid out there that the events are the ones we currently measure are long delayed in many cases, potentially from intervention in children. So this bridging strategy could be challenging. And I think what we haven't really discussed is the kidneys are being damaged starting at an early age in many cases, and the markers of kidney function and things really aren't measuring that destruction. And so when we think about other measures around kidney, whether they be structural biomarkers or yet to be developed functional markers, are there ways that people are thinking about where we could really start measuring progression of the disease early as reflection of the tissue that's being destroyed by progression?
Yeah, and Ron Perrone in the chat room just suggested perhaps more novel imaging techniques. For example, quantitative texture analysis is one way of doing it. So maybe an alternative imaging biomarker is a possibility. I think, Jalila, I think you have new data too, right, about MCP1 in kids?
Yes, so we are working really on, we have built in a very nice longitudinal biobanking where we are evaluating all the validated biomarkers in adults and to show if they are already present in childhood. And we published just that actually copeptine and EGF was not significant from healthy controls. However, we showed already that urinary MCP1 is already increased. And we are indeed also working on childhood with our technique of TKV and 3D ultrasound to count the number of cysts and to have also the cystic volume and to try to define indeed the normal kidney parenchyma in comparison with the cystic one. So we are indeed moving. However, the trials now, it will be very difficult to apply already our results. And I think that long-term follow-up will help us more and more.
So just so I can clarify the bridging biomarker strategy. So the events would have to occur relatively close in time to the trial for the bridging biomarker to be considered informative. So if I gave an example, if MCP1 was a valid biomarker in progressive childhood ADPKD, that bridging biomarker would have to associate with new onset hypertension in a large number of individuals fairly close to the time that the trial was done. Is that the concept? And I apologize that I don't know about this better.
Yeah, and I don't think I was quite that strong about this. I just think it's harder to expect that for preserving the pharmacologic action of a drug in children, it's harder to believe that's going to translate into clinical benefits if the clinical benefits aren't going to be manifest for decades.
Got it.
Something
It's
earlier
much
on
easier
is, yeah,
if you
that's
think
very.
if you think they're happening in real time.
Yeah.
Yeah, so I mean, I think at least in the natural history of ADPKD, and I think Dalia's shown it in children, hypertension is probably the most closely linked to cyst burden and the most frequent complication. You know, and at least in the TEMPO trial secondary analysis, it looks like therapy was associated with a change in blood pressure too. So, I mean, these are not very hard endpoints, but these are the kinds of things that young adults with ADPKD and children with ADPKD do develop.
Yeah, and I think to answer our continuously discussion with Roser that the children are much iller, I think that the pediatricians are evaluating this much details because the pediatricians are much structured. They like details. They like, and we are doing a BPM regularly, and we are. I don't think that the adult care is doing such precise things that we do because we have, of course, a smaller group, but we are doing really the hypertension with a BPM, and we are showing this, that they have left ventricular hypertrophy and they have this nocturnal hypertension. So it is really very well studied. So I agree with Arlene that that hypertension might be really one of the important thing that we should look at. And with these early biomarkers that are coming, and urinary MCP1 is really a novel candidate. We need to validate it. Of course, I show it in a small cohort, but it was a very well characterized with matched healthy controls. So it was a very clean design. And we need to validate it more. And I think that this, so I totally agree with Arlene.
Yeah. And I hate to jump in and cut this conversation short because it's a fabulous conversation. What I take away from this is, again, it gets back, part of why we wanted to have a discussion that was both adult and pediatric is the ability to have a discussion where we're talking really about the bridging of the continuum of disease and what can we learn from what's being done in study the adult population, the child population, start to build this bridge. But in the last few minutes, it would be great to talk about the liver. And so if we could flip the next slide, Wendy. And I think, I think just to cut to the chase, in the first session, Dr. Turner and Dr. Stockbridge, I think there was a really great discussion starting about how do you manage the clinical evaluation and development of drugs for indications where both the liver and the kidney are impacted. And so I'm wondering if maybe in the last, 5-ish minutes, we talk about that aspect of drug development for ADPKD and thinking about labeling around the liver and how that might impact your views on trial design.
And many in the chat are asking this question.
Joe, do you want to start?
Yeah, this is Joe. I can go ahead and start. I think, as I mentioned this morning, that it's an interesting concept that the evaluation of the liver in any new drug development. You're going to want to evaluate the liver in terms of safety evaluation. So that's going to happen on a regular basis. You're going to, that's going to be a standard evaluation for any new drug. But in this particular space, it might be interesting to include, and I recognize that liver imaging isn't a part of that standard safety evaluation, but I would think in the context of these trials to go ahead and include liver imaging as a non-invasive biomarker, is a safety, non-invasive safety biomarker. If you read actually our drug-induced liver injury guidance, it does provide some comments about liver imaging that might be important to evaluate for potential for liver injury. So I would think just in the context of safety, you could easily incorporate a liver imaging biomarker into these clinical trials. And just before we end, I just wanted to clarify too, I didn't mean for my earlier comments to be construed in any way about accelerated approval. I think this is a space where, serious disease, unmet medical need clearly fits in accelerated approval framework for regulatory approval. But my comments were really kind of to get you all to think about, well, what happens to confirm clinical benefit? If the clinical benefit is years down the road and you have accelerated approval, as a regulator, I want that post-marketing trial to be adequate and well controlled. But as a clinician, do I really want my patient to have years and years and years of placebo treatment? So it's just very difficult for industry and for academia to have these lengthy post-marketing confirmation of clinical benefit studies. So it's part of why I was challenging and pushing you all to think about this, a bridging biomarker, or one that can be verified as having clinical benefit in the context of drug development. And I guess there are some examples out there, and it's often not fair to use HIV as an analogy, but my colleague Jeff Murray in Antivirals had published how and the data that was needed for viral load to be the efficacy endpoint to be used for drug evaluation. So that was done. I was in the Center for Biologics when the first vaccine was evaluated for human papillomavirus vaccine. And the work done to show that the pap smear and prevention of cervical intraepithelial neoplasia, that was the endpoint. It wasn't a clinical prevention of cancer endpoint. It was an endpoint based on a biomarker. And so those vaccines to prevent human papillomavirus as a cancer prevention vaccine, those were all that work was done before the phase 3 trial was initiated. And it's a lot of work, a ton of it's not easy. you have a long road ahead, but we're willing to help you with some examples to get you started and think about this. Think about biomarker as being the endpoint, I guess is my message. To the extent of having a liver endpoint being the efficacy endpoint, we're willing to help with that. And again, I mentioned this morning, there's a robust qualification development that's going on in the liver space to qualify a non-invasive testing for liver outcomes. So I'm encouraged by that robust qualification effort, and so I just wanted to explain some of the context of why I was making those comments in the direction of, well, let's try to have the biomarker as the endpoint.
Nice. It's interesting with polycystic liver disease, even though there can be very significant liver cyst burden, most of the synthetic function in the liver is completely intact. There are no abnormal liver function tests per se. And so, we worked very hard in the kidney space to get cyst burden sort of as a endpoint of interest or a biomarker. To a certain extent, that's been successful, but not as an endpoint alone. Do you think that could happen with liver cystic disease?
And I think, again, it's data that, to be generated and shared with FDA in that direction. But if those data can be generated, and there is an association with certain size of the cyst or amount, if they can clearly be correlated with rapid advancement or advancement years down the road, if you could correlate that with, then the prevention of development of new cysts, or that could potentially be useful as the endpoint. Or as an endpoint reasonably likely to predict clinical benefit, for accelerated approval. But again, we're left with, well, how do you confirm clinical benefit in the post-market setting? And and it can be done. I'm not saying it can't be done, but it's just something to think about.
Yeah, and I'd give Dr. Stockbridge a real quick point to comment, but I think Ron just put an important point in the chat that this sounds like a nice point to continue PROs for polycystic liver disease, maybe in combination with imaging endpoints, with a lot of the imaging already picked up in the general abdominal imaging studies, right? So it's not as if the data might not already be sitting there from some of the imaging work. But we're approaching the close of time, and I don't know, Dr. Stockbridge, if you had a comment on this topic.
Only to say, we'd be happy to consider a composite that includes multiple organ systems as potential sites for benefit. And we can certainly work with the relevant review divisions to make sure that they get the data that they need to support a claim that encompasses those. I am, however, less optimistic about the prospects of doing an accelerated approval in a setting where it's going to take a long time to get confirmation. That's time that people are taking a drug without proper assurance that it actually is going to improve their outcomes. Because if you knew that, you wouldn't have given them accelerated approval.
I totally agree. Yeah, good point. Thanks, Norman.
No, thank you. And I'm just, we're eating into John Michael's closing time. So my only comment here as we start to wrap is, we missed this question entirely, which is unfortunate, is you've been a fabulous panel, and I just really appreciate your thoughtfulness and time. I would, Hayley's been sitting over here listening intently. I would mind her 30-second or so perspective on this, and then maybe hand it over to you, Arlene, and then to John Michael, and we'll say just thanks for the day. So Hayley, any 2 cents?
I really appreciate what everyone had to say. I think one thing I'd like to respond to, I can't remember who brought up this point, but it was about testing younger populations in clinical trials and, the risks of doing that. And I think on one end of the spectrum, I'm, at least for my age group, I'm still looked at as like a completely healthy adult, even though I've already been diagnosed with this disease. And I am a healthy adult by certain means, but I think that also is a good reasoning for why I would be a better candidate, because I don't have these comorbidities with me, and I just think that I'm not on as many medications, and I don't. I think I'm just a healthier population, so maybe there would be less risks and side effects. And then, yeah, I think that was like the main point I wanted to take away from. And yeah, I'm sorry, I kind of lost my train of thought, but that was something to me.
Thank you. Thank you so much. And Arlene, any parting shot?
There was a discussion about events occurring and how they don't occur in younger populations. And I just definitely would love research to focus more on that, because I really do believe there are events happening right now, whether they're in the urine or in the blood, and we just have not found them yet, but they are really important. Just because I'm not where the clinical measurement says my kidneys are failing, like I can feel the events. I know that they're happening, through infections and hypertension and things like that. So what measurement is needed to deem those like extraordinary or significant on a clinical level, I think that needs to be too.
Thank you. Excellent point.
That's great. That's really important. I think this was really helpful from my perspective to start thinking in an innovative and creative way to really tackle how do we take a drug that we think we show is effective in young people with ADPKD, where it can't rely on the typical slope of eGFR, doubling of serum creatinine change, or a 40% reduction in kidney function. We can't. PKD is not that kind of disease. So it was really exciting to hear the different ways of potentially approaching this today. I was very thankful for that. So I think that was terrific.
Awesome. Well, thank you all panelists. And thank you, John Michael, for giving us 5 minutes, and I'll let you close up day one.
Well, thanks a lot, Chris. Thanks, everybody. This was really a great day. I think what we heard was really the power of the patient's voice, directing us on where we need to go as basic and clinical researchers, as well as regulators. I think that's really important, right? Likewise, I think we see the power of collaboration in what we did today, right? We had folks from academia, from industry, from the health authorities, all working together trying to problem solve around these diseases. We see that AR PKD really doesn't have a very firm pathway at this point to go forward to introduce therapies, right? And to have those therapies accepted by regulators. And so that tells us that we need to do some work really early on, maybe in the basic space, right? To be able to understand how we can pull biomarkers forward, get those biomarkers actually accepted by regulators, and then create that regulatory pathway that drug developers are looking for so that they can invest in these therapies for patients. I think in AD-PKD, I think we're in a different space, right? I think, as a community, we've done a very good job at creating a regulatory pathway. Does it need to be refined? Yeah, there's no doubt about that. But we have a pathway to refine, and we have a lot of work to do there now. But I hear a lot of optimism in the group, right? I hear a lot of give and take between the academics, the scientists in industry, and especially the regulators trying to figure out a solution. And that's why we're here, right? To figure out those solutions. So tomorrow's going to be fun, right? Because we're gonna basically bootstrap off of what we did today, right? And we're going to think about where are those most impactful solutions that we can come up with, and how do we then invest in those, right? And collaborate on those as a community to go ahead and make sure those drugs are available for patients in need. I'm really excited about session 3B, especially because there, I think we're really going to have a deep conversation around exactly how we need to design AD-PKD trials and shared learning around the experiences that we've already had. And so I realize there's not a guidance out there around how to design these trials with AD-PKD, but I think this is going to be a step towards that, right? To be able to share as a community how we best advance. So I'm going to wrap things up and say, see you tomorrow. So thank you, everyone.
Bye, everybody.
Bye-bye.